And we're there. Good afternoon, everyone, and welcome to the Health and Government Operations Committee. For those who will be participating and providing oral testimony this afternoon, please remember never to forward the Zoom link for the hearing. Staff will not allow anyone into the Zoom who is not invited to testify. And I'd ask you to encourage folks to watch the committee hearing on YouTube. To be clear about the timing, the bill sponsor or the designee of the sponsor has 5 minutes to present a bill. 5 witnesses will be allowed to speak for 2 minutes each in support. And we need people to stay in the hearing until delegates on the committee have had the opportunity to ask questions. Next 5 witnesses will each be allowed to speak for 2 minutes in opposition to the bill, and then have the opportunity to respond to questions. Please conclude your remarks when you see the timer finish. Committee members must remain present with your video camera on during the entirety of the meeting. And committee members, I would remind you, please only ask 1 question of 1 witness. If you have other questions, you may follow up offline. Please use the raised hand function to indicate that you have a question. We have 10 bills today, and we are going to begin with House Bill 736 by the Speaker at the request of the Governor, and that is Interstate Licensed Professional Counselors Compact, and I'm going to invite Jake Whitaker to explain the bill.
Great, thank you, Delegate. Madam Chair, members of the committee, my name is Jake Whitaker. I'm with the Governor's Legislative Office here to testify in support of House Bill 736. This bill is part of the Governor and Lieutenant Governor's commitment to addressing the heroin and opioid epidemic, and it achieves this by increasing the number of professional counselors available to Maryland patients. The Counseling Compact preserves the authority of each member state to protect the public health and safety through existing Maryland regulatory and statutory structures. House Bill 736 will also allow the board to continue to determine the requirements for licensure, as well as maintain the unique scope of practice for counselors here in Maryland. To utilize the compact, a professional counselor must have a license in good standing in their state, and that's the state where their primary residence is, and the home state must be a member of the compact. House Bill 736 also helps protect public safety by requiring minimum educational and licensure requirements for states choosing to join the compact. So for example, if a state has very lax licensing or testing requirements, they may not be eligible to join the compact. Additionally, I wanted to point out to the committee that we've consulted with stakeholders on this bill. We've determined that the need for additional counselors is immediate. There are counseling centers that say, hey, there are counselors in Delaware that could assist our patients immediately. And if we had this bill go into effect, we could serve those patients. So in summary, this bill will reduce barriers to access for patients. It will also increase choice for Maryland patients in terms of the number of counselors available. This bill will also protect the patient safety of Marylanders by ensuring that adverse actions and disciplinary sanctions are reported directly and shared with member states. It'll facilitate the sharing of that information, and it will also require background checks for those folks participating in the compact. So for the aforementioned reasons, we respectfully request the committee accept the amendment and vote favorably on House Bill 736. I'm happy to answer any questions, but if okay with you, Delegate, I'd like to turn it over to Dr. Jones.
Dr. Jones? Yes.
Hi, good afternoon. My name is Dr. Alia Jones. I'm the Deputy Secretary of the Behavioral Health Administration, testifying in support of House Bill 736. If passed, this legislation would have several benefits, including but not limited to improving the continuity of care for individuals traveling or relocating to and from other parts of the United States to Maryland, improving access to mental health care for populations such as students, active duty military, and their families who are using the civilian system, eliminating the necessity for licenses in multiple states, allowing Marylanders who move to compact states to continue their behavioral health services. And lastly, it would provide Maryland's authority to hold a licensed professional counselor accountable for meeting all the practice laws in the state of Maryland if their client is here, thereby protecting public health and safety. The National College Health Assessment and the Healthy Mind Study between 2007 and 2018 found a worsening of depression, anxiety, low flourishing, and suicidal planning and attempts among college students, with suicidal thinking, severe depression, and self-injury rates doubling between 2007 and 2018. Maryland has more than 50 colleges and universities and over 130 private career schools and several military bases. Our universities enroll over 345,000 students in the fall of 2020. And because we have such strong schools in the state of Maryland, we have a lot of students who come here from outside of the state. Approximately 1 in 3 undergrads, or 1 in 3 graduate students, or 1 in 4 undergrads are enrolled at the University of Maryland, come from out of state. The impact of COVID has shown that these populations are at particular risk for increased mental health support and behavioral health needs. The need to access services as they move in and out of state for school or service obligations must be provided with open access and minimal interruptions while students are learning or military persons are working in the state of Maryland. The added stressor that relocation can cause, even though it might be a positive stressor for many, can make many individuals more vulnerable to increased risk for crisis levels of stress, anxiety, and depression. The need for mental health supports for college students who may live outside of the state but attend Maryland colleges and universities has caused a strain on the school counseling centers, and therefore Maryland Department of Health respectfully requests a favorable report on HB 736, which can help Marylanders more readily access the behavioral health care that they need and also preserve the continuity of care. Thank you.
Thank you, Dr. Jones. Christopher Arnold.
How many years have you been in government?
Good afternoon, Madam Chair, Chairwoman Pendergrass, honorable committee members. It's nice to see you once again. We appreciate the opportunity to support House Bill 736. My name is Christopher Arnold. I am the Northeast Region Liaison for the Defense State Liaison Office, operating under the direction of the Undersecretary of Defense for Personnel and Readiness. Our mission is to be a resource to state policymakers as they work to address quality of life issues for military families. Joining the compact before you today will improve access to care and allow military personnel and spouses to more easily maintain their certifications when relocating. DoD encourages states to simultaneously fulfill what can be done as far as immediate actions, near-term actions, and long-term solutions, such as interstate compacts for military spouse licensure. Military spouses are a cross-section of the American population. Although a greater percentage of them are in licensed occupations than their civilian counterparts, they are significantly more mobile. Barriers to the transfer and acceptance of certifications and licenses that occur when state rules differ can have a dramatic and negative impact on the financial well-being of military families. Compacts can provide seamless reciprocity for military spouses in an occupation. The secretaries of the military departments have made the importance of military spouse licensure explicitly clear as they consider the availability of military spouse license reciprocity when evaluating future basing or mission alternatives. How fast these actions and solutions can be approved and implemented is up to the states. Occupational licensure compacts provide consistent rules for licensed members to work in other states. The military provisions added to these compacts assist service members and their spouses. The benefits to the military are clear. The Interstate Licensed Professional Counselors Compact, or LPCC, seeks to eliminate barriers to interstate professional counseling practice, improve patient access to professional counseling services, and enhance public protection through a shared interstate licensure data system. Of additional benefit is the compact's utilization of a mutual recognition model of interstate practice, which enhances opportunities of portable careers for military spouses by providing consistent rules which allow licensed members to work in other states through privilege to practice policies or more easily transfer their license to another state. Joining LPCC will improve access to counseling resources and allow military personnel and spouses to more easily maintain their certifications when relocating. As always, as Northeast Region Liaison, I stand ready to assist and answer any questions you may have with respect to DoD position on this item and our support for interstate licensing compacts. Thank you.
Thank you, Mr. Arnold. Rachel Faulkner.
Hi, good afternoon, members of the committee. Rachel Faulkner here with the Licensed Clinical Professional Counselors of Maryland to support House Bill 736, which would enter Maryland into the Interstate Licensed Professional Counselors Compact. This compact was developed by a national task force, which included various stakeholder groups, including the Licensed Clinical Professional Counselor of Maryland's a national affiliate, the American Mental Health Counselors Association. First, I just want to thank the governor and lieutenant governor and the Behavioral Health Administration for recognizing the real importance that licensed clinical professional counselors within Maryland behavioral health workforce play in the state by introducing this legislation. Currently, there are over 4,000 licensed clinical professional counselors in Maryland, and within their scope, they can diagnose and treat mental health conditions in various practice settings. We see several benefits of the compact, including access to behavioral health care, improved continuity of care, and improving workforce shortages. I think we all knew that before the current healthcare pandemic that Marylanders across the state experienced difficulties accessing behavioral health. We've seen the importance that behavioral health providers, including LCPCs, have played over the last year in really, very quickly pivoting to a mostly telehealth environment to really meet the demand for those who were already receiving services and for an increase in demand from folks experiencing mental health conditions through this pandemic. We want to highlight the inclusion of telehealth in the compact as it's really plays an important role in ensuring that professional counselors abide by state rules in their home state and in the state where they may relocate or where a client is located. I think you heard from Mr. Arnold and Dr. Jones some of the real benefits of the compact, and for these reasons, we would urge a favorable report. Thank you.
Thank you. Jeffrey Galecki.
Hi, I'm the board chair for the professional counselors and therapists, and we voted unanimously to support this measure for the reasons already listed above of portability, increased access to care for patients. We are also licensees, most of us, and this enables us to practice in more places. We don't see any risk as far as protecting the public as regards to education standards or to criminal background checks, as that's all been addressed in the compact. We also will take an active interest in, if this measure was adopted and put into law, the ultimate commission that would be set up to start the framework and enact it. So we're very committed to this process, and we also ask for a favorable report on this. Thanks everyone for your time today.
Thank you. Are there committee members? If you have a question for this panel, please use the raise hand function. I see a question from Delegate Bandari.
Yeah, thank you, Madam Chair. This question goes to Jake. Thank you for bringing the bill. If our state enters the this compact, a lot of professional counselors who are licensed in Maryland but reside out of state, they might not renew their licenses. So we might be losing the revenues, the board special fund revenues. Would you like to say something on that?
So I think that's reflected in the fiscal note. And I think that is a consideration, and perhaps the board chair may be able to speak to that, but our main concern is increasing access to available providers. And we think that balancing that with the risk to the revenue from licensure is worth it to make sure that folks have the substance use and counseling services they need.
And following our one question, one witness, if you need to follow up Delegate Bandari with the board president, please do. Delegate Saab.
Thank you, Madam Chairman. My question is, and I don't know if I missed it in the bill or the testimony, what are the states that are entering into the compact, or are we just starting a whole new compact? Are we just adding into an existing compact?
So this will be a brand new compact. We believe that we'll meet that threshold, which is 10 member states, and kind of coordinating with the Council of State Governments, they believe we'll hit that threshold this year. So that's part of the reason why we're moving forward with the emergency amendment to make this official, so that as soon as the member states join in, we're able to move forward.
Thank you. Thank you, Madam Chairman.
You're welcome, Delegate. Chairman Pendergrass.
Unmute. Yeah.
Chairman, you're on mute.
That was an excellent question from the chairman.
Unmute, Chairman.
I apologize. I'm not on my normal computer. Mr. Whitaker, could you tell me how much money was taken out of this board's funds to help balance the budget this year?
I cannot, but I'd be happy to follow up with you, Madam Chair.
That'd be great. Thank you very much.
Absolutely.
Are there any more questions of this panel? Okay, we have no more witnesses for this panel, so thank you very much for bringing us this bill today, and we will move to that concludes the work on 736, and we will move to House Bill 873, Delegate Charles, and that is the State Board for Certification of Residential Child Care Program Professionals, Certification Revisions. Delegate Charles.
Thank you, Madam Chair. I have someone that should be coming on board as well. Melissa, is everyone in? Do I have anybody in the waiting room?
Everyone should be in now.
Okay. Good evening, committee, Chair Pendergrass and distinguished members of Health and Government Operations Committee. This is Delegate Nick Charles. I'm asking for a favorable report for House Bill 873, which is State Board for Certification of Residential Child Care Program Professionals, Certification Revisions. This important piece of legislation proposes requiring the State Board for Certification of Residential Child Care Program Professionals to maintain an electronic roster of all individuals certified by the board. This electronic roster would be made available for verifying certifications on the board's website. If an individual does not have access to the board's website, they may contact the board to verify a certification. Additionally, this bill will alter the language used in the renewal notices for child care programs to facilitate easier access to renewal. The State Board for Certification of Residential Child Care Program Professionals' mission is to protect children living in Maryland's residential child care programs and to promote quality of care in the field of residential child care. By requiring this board to maintain an electronic roster of their certified individuals, Marylanders have better data to transparently research whether a residential child care program is meeting standards of regulation. And this would be a protective measure to ensure Marylanders know exactly who they are dealing with and who they're leaving their children in care of. The state of Maryland thrives when we have an increased transparency between our boards and the constituents. I've asked for a favorable report, and I will pass on the rest of my time to my sponsor committee.
Delegate, do you have someone you'd like to follow you?
Yes, it's Lillian from the Department of Health.
Hi, I'm actually here representing the board. I'm Nicole Smith. Thank you, Delegate
Okay.
Charles. If it's okay if I go.
Yes.
Okay, perfect. Hold on 1 second, please. Good afternoon, Madam Chair and committee members. I'm grateful for this opportunity to be here today to speak in support of House Bill 873. My name is Nicole Smith, and I serve as the Secretary for the Board for the Certification of Residential Child Care. In my day job, I'm actually a certified residential child care program administrator for the Board of Child Care, a multi-human service nonprofit that delivers residential treatment services and is licensed by the Department of Human Services. The State Board for the Certification of Residential Child Care was established in 2004 and governed by the Health Occupation Articles of COMAR. It's generally funded. The board certifies residential child care administrators like myself and residential child and youth care practitioners who provide direct care services in support of the youth that reside in residential child care programs. The mission of the board aligns with my life work. As Delegate Charles said, to protect vulnerable youth as they reside in residential child care programs and they're recovering from adversities and traumatic life events, as well as to promote best practice and quality services. Currently, there are 1,167 certified residential child care program professionals and 80 certified program administrators. The passage of House Bill 873 will allow the board to move to a paperless electronic verification system for all individuals certified by the board. This process has already been adapted by other health occupation boards with favorable results. Moving to the system will allow for efficiencies to the certification process that will positively impact board resources, the experience for the licensee, and the residential child care program providers. There is no fiscal impact with moving to this online platform, and the fees will remain the same for licensees. Moving to a paperless system will promote eco-friendly practices while reducing waste, cost, and storage space needed for records. The online system will shorten the process for certification and increase the licensees' accessibility to their certification information to an on-demand basis. If an applicant does not have access to the board's website, the board will be equipped to provide paper license verification and a paper certificate. Thank you for your consideration of this testimony. The State Board respectfully requests a favorable report on House Bill 873. Thank you.
Thank you, Ms. Smith. I'll turn it over now to Darlene Ham.
Thank you. Good afternoon, Madam Chair and members of the committee. Thank you for allowing me to testify before you today. My name is Darlene Ham, and I am the Executive Director for the State Board for Certification of Residential Child Care Program Professionals. I'm here today in support of House Bill 873, revisions to the Maryland Code Health Occupation Article 2307. I'm here to answer any questions and will provide clarification that you may need. I'm going to share a few examples of the benefits of paperless license relative to the duties and responsibilities of the board staff. Currently, we have 2 board staff members that are responsible for 1,171 certified residential child care program professionals. This number is steadily increasing with staff certifying and reinstating licenses daily. License renewals are done annually, and as a result, licenses are being printed and mailed frequently. During renewals, there may be at least 400 licenses of both program administrators and residential child and youth care practitioners within the same year. The licenses are required to be printed off and mailed out to the licensees to continue to work, and they must be displayed on site at the program. Paperless licenses will allow the licensees to have access to their licenses at any time through electronic devices with internet access. The license can be printed off at home and can be readily available for employment purposes, job interviews, or just for them to review. Paper licenses will still be available without access to the board's website, and the licensees will still be able to contact the board for verification. Thank you for consideration of this legislation, and for this reason, the board is requesting a favorable report on this bill. Thank you.
Thank you, Ms. Ham. I'd like to call William Spate.
After several emails, Mr. Spade's not with us.
It's not with us. Okay, then that concludes the panel. If you have committee members, if you have a question, please raise your hand. I see Delegate Kelly.
Thank you, Madam Chairman. I really like this bill. I just have a really simple question. It seems to make sense, but for those folks who don't have access to the internet, can you just walk me through how the alternative process would work for them to get access to the paper process?
Yes, they would.
Yeah.
Oh, go ahead.
No, so I'll pass it on to you, Darlene.
Okay, thank you. Yes, the licensee would still have the board staff available for them, and the licenses will still be able to be printed, and they can contact the board for any verification of their licenses.
So instead of going through an online process, they would just pick up the phone and call and have their needs met in that way?
Yes, we will send them a paper license if requested.
Great, thank you.
Mm-hmm.
Thank you. Delegate Saab.
Thank you, Madam Chairman. Are there any current requirement now for posting the licenses on the premises?
Who's best suited to answer that? Tam, perhaps?
Yes. The licensee is supposed to have their license available for them for their records and at their program if requested.
So they're not required to post it. I guess my question with this one, if we're gonna do away with paper licenses, do they have to, are they required to post it? Or they are required to have a copy of it and they're printed, have a copy in the file instead of you sending them a paper copy? But they still have to post it.
No, well, it wouldn't have to be posted, but they would have to have a copy of it for their file.
Okay, thank you. Thank you, Madam Chairman.
You're welcome, Delegate Saab. Delegate Bagnell.
Thank you, Madam Chair, and thank you to the bill sponsor. Just a quick question. Is this bill, and I apologize if you said it already, is it in the same posture that it was when it passed out of the House last year?
Yes.
Thank you. Thank you, Madam Chair.
You're welcome. Are there any other questions? Seeing none, that concludes the hearing on HB 873. Thank you all for being here to testify today. And thank you, Delegate, for bringing us the bill. We will move to House Bill 806, Delegate Karen Lewis Young, and it's Health Facilities, Nursing Homes, and Assisted Living Programs, Essential Caregivers. Delegate Lewis Young.
Thank you, Madam Chair, for an opportunity to present a bill that will strike a better balance between mental and physical health for residents of long-term care facilities and help families avoid the challenges that I experienced for 9 months of 2020. What this bill will do is allow residents of long-term care facilities to designate an essential caregiver. That individual will be authorized to advocate or provide additional personalized care for the resident. The facilities could direct or establish policies and procedures to authorize the indoor visitation from a point of entry, such as a side or a back door. And they would require screening, such as we experienced to get into this building. It would also require essential caregivers to abide by rules and policies adopted by the facility that would ensure patient and resident safety. The bill also states that if a patient or resident is quarantined, an essential caregiver may not visit the patient or resident until the quarantine ends. I'd like to tell you the experience that motivated this. In July of 2020, I drove down to Florida, which was at that point in time the #1 state in the country for increased cases of the coronavirus. I felt like I was on a rescue mission going into enemy territory, but I brought my mother back to Maryland because I wanted to provide a greater role as a caregiver. I got here and found that once a week for half an hour, I could visit her 10 feet away from a porch while I was eaten alive by bugs. I watched her deteriorate mentally first from confusion, loneliness, fear, depression, and uncertainty. The physical health deteriorated, I believe, corresponding to the mental health challenges. Fortunately, Dana Kaufman contacted me and told me about revised CMS guidelines for compassionate care. And I contacted the facility and said, my mother qualifies on all 5 criteria. Please let me in. They should have contacted me. I contacted them and made the case. I think you all know I'm not shy, but how many other families out there don't know about that, don't have the resources, don't know that they can make the case? Well, once I got in, I essentially became her unofficial caregiver. I found terrible things. I'll go through a short list. The facility said that she had an oppositional disorder. I retorted to them, she's dying. Don't you understand depression and fear associated with dying? I found a bruise on her arm one day and asked her how it happened. And she said, well, they were in a hurry, so they lifted me too aggressively. One day her pajama bottoms were off and I asked why, because it was cold. They said, it takes us too long to put them on. And another day, an aide came in and said to me, has she had her meds yet? I said, I don't know, I just got here. Don't you check the records every day to see what meds? Whoops. And they said, no, we didn't check yet. We thought maybe you'd know. Those are just some small examples of the nightmares that I experienced for several months. You know, would being able to get in as a caregiver sooner made a difference in my mother's survival? She passed away on December the 14th. I don't know, maybe not. But would she have had a better quality of life for the past 6 months of her life? Absolutely, she would have. And I wouldn't live with the regret that I do today of her one day saying to me, if my mother and father were alive today, they'd get me the hell out of here. I have to live with that and deal with it the best I can. But hopefully, if the issues in this bill are addressed, other people won't. Thank you.
Thank you, Delegate, for sharing your story, and we're very, very sorry for your loss. I'm going to ask Elmer Dangler to speak. He has favorable with amendment before we ask questions. Mr. Dangler?
Thank you very much.
Melissa, is Mr. Dangler in the room?
He is. He needs to unmute himself.
Okay.
Hi. You hear me?
We can, sir. Thank you.
Okay, I'm ready to go. My name is Elmer M. Dangler. My mother has been in a nursing home for approximately 10 years. And through that time, I have been her primary caregiver and have seen what nursing homes can and cannot do. The last 2 years prior to the pandemic, I provided 4 to 5 visits a week, staying about 3 hours each time. During that time, I provided her with music of her life through the Alive Inside program, which I brought into the nursing home. Having the music playing in a headset enabled a reduction in pain medicine and a significant easing of her anxiety and fear. Usually after the headset had been playing for half an hour, she was able to converse with me and I was able to hand feed her. Because the music of their lives has been shown to help the brain reconnect with the outside world, I was able to find out what her needs were and concerns, and was able to answer her questions as family and to solve her problems. Because of my time there and the process I was using, her anxiety through the dementia process was greatly eased, a minimum of time and stress to the staff and faculty. I ask that facilities be encouraged to also adopt a Alive Inside program, and I also ask that the facilities, this body also consider a trial funding of the program and that this be open to all residents in the facilities, not just the elderly. And I thank you very much for allowing me to speak on this topic.
Thank you for your testimony, sir. I would like to open it for questions from the panel or from the committee. Are there questions of this panel? Give you a minute. I see no questions. Then we will move to an unfavorable testimony. Dana Kaufman.
Madam Chairman, I think Delegate Riley has a question.
Um, Delegate Riley. Okay, just turned up. Thank you.
You're on mute.
No. Yes, thank you. Thank you, Madam Chair. I just had a question to the sponsor of the bill. Thank you. I think it's an excellent bill. Did you see a letter from the Maryland Department of Health? Does this bill, I think, kind of just takes care of their issues in a better way? Would you like to respond to that, or?
Thank you for that question. I did see the letter from the Maryland Department of Health, and they talked to the role of OHCQ. And they said OHCQ provides oversight, but our experience in our committee has been that because of OHCQ chronic understaffing, they're reactive, not proactive. And in fact, we've been asking for years for COMAR updates of the regulations for long-term care facilities. They haven't been updated, I think, in 10 or more years. And they have said, well, we can't get to it yet. So I'm a little bit concerned about relying on OHCQ as the solution to some of these issues.
Okay, so I agree with that. So in follow-up, they were actually in charge, and they could have done this during this time of what you just experienced, but yet it wasn't taken care of. So that proves the fact that the bill is probably needed at this point.
There are several bills on some of the same issues. I think issues need to be addressed in some manner. Yes,
Okay.
I'll agree with that.
All right, thank you.
Thank you.
Delegate. Delegate Saab has a question.
Thank you, Madam Chairman. I just wanted to just bring to the attention of the committee and the sponsor the Facilities Association opposition letter. Most of us or all of us read it. Delegate Lewis Young, can you comment that on the HFAM's position?
I'm sorry, I had to turn the lights back on. They went off on me. Which letter are you referring to?
The letter from HFAM, the letter of position. I know there's some issues that they've pointed out. I just wanted to give you the opportunity to address that.
Yeah.
You went back on mute.
I'm
back on mute.
Back on mute. Okay. The one thing that really, there were two things that jumped out at me at the HFAM letter. They did talk about the physical health risks, but they never mentioned the mental health risks. And that's a large part of my point, that particularly with the elderly, we need a better balance of the mental and physical health issues, because the mental health issues are directly influencing the physical health issues. The other thing I noticed in their letter was many healthcare organizations brought iPads, handheld devices, and laptops. Most elderly people are not comfortable using iPads and laptops. It was my experience that the staff did not have sufficient resources to help residents do that. And in my case, my mother was deaf. She couldn't communicate with anybody that way. She read lips, and in my case, she understood my voice, but for some reason she couldn't understand anyone else's, just my voice. I don't know if I'm loud or maybe she was just used to it, but that was an extra barrier she experienced. So that solution isn't always relevant. Thank you for the question.
Thank you, Madam Chairman.
You're welcome, Delegate. Delegate Hill.
Thank you, Madam Chairman. Delegate Lewis Young, I'm really very sorry for what you experienced. I've certainly seen a lot of care over the years in nursing homes, family members, and patients that was less than one would want. Do you have a sense of how much of the mental health deterioration that you saw with your mother in this particular case, or with other residents, might have been attributable to the fact that, in addition to not having visits from family, because some residents never get visits from family, but they also, because of COVID, were limited in terms of interactions. Many of them had to stay in their room. They couldn't go to common areas. Any sense of how much that was a role, and whether going through a period like that, you would expect different kinds of, in your bill, you would expect a different kind of response in times where the residents are not even allowed to interact with each other?
You know, I only had one experience because obviously I couldn't interact with other residents, but I know when my mother was allowed to, you know, go to the dining hall, that did help a little. But again, in her case, she was limited because of her hearing disability. But, you know, clearly, in so many cases, and now I'm just referring to the data and the studies I read, because for months I was absolutely obsessed with reading everything I could on the topic. And I saw that this, you know, lack of social interaction and the inability to interact with family was having a devastating mental effect on individuals in long-term care facilities, and particularly for those with dementia, their family and interaction with their family was their only contact, was their only touchstone with who they were, what their identity was. And as they lost that, they lost everything.
Thank you.
Thank you, Delegate. Delegate Salega.
Thanks, Madam Chair. Thanks, Delegate Lewis Young, for bringing this bill. My father's in a nursing home, and my mom sent me a text today that he's in the nursing home wing of a CCRC, that she is still not permitted to see him, even though he has the vaccine and she has the vaccine. So I firsthand know what you're talking about. So have you asked the folks, and I will ask them when they come up, have you considered like sign off paper? You know, I understand that the nursing homes are concerned about reporting out COVID deaths. You know, they, in a year, you know, these are businesses, they care for people. I'm not saying they don't care for people, but, you know, they're going to need to report out, look at how well or poorly we did with COVID. And so we know that, you know, the reason they're taking these proactive stances is to, you know, prohibit spreading COVID to folks who we know could very possibly die from it. But as my mother says, why can't I sign a paper that says, I won't hold you responsible? You know, potential, have you considered any of this? Make a second category so these nursing homes don't get dinged. Or, as my mom says, look, we're all dying. My husband's dying. You know, she's probably seen him 10 times in the last year. So I'm with you, but have you considered any of these other things?
That's certainly a good idea, but you bring up a really important point. Again, what I found through my research is that wasn't families, and in my case and a few other cases, if the resident qualified for compassionate care, ultimately we could get in. It wasn't the families that were bringing the virus in. It was staff, it was workers. In fact, when my mother was alive, I was more cautious. My husband watched me jump 6 feet across a sidewalk. And when people looked at me like, what's wrong with you? I would say, I have a 93-year-old mother. I took more precautions because of my fear of contaminating her than I probably would have otherwise.
Well, I'll be sure to ask when they come up if there's some way, because I think we all understand the challenges and it'll be good to hear from them. Thank you.
Thank you.
And that is the last question. So you'll have a chance to do that, Delegate Szeliga, because I'm calling up Dana Kaufman.
Thank you very much. For the record, my name is Dana Kaufman with, sorry, the screen kind of went funny there, with Schwartz, Metz & Wise, and I'm here on behalf of Lifespan Network. And I'm glad to be here today because I do know that the visitation restrictions have been so hard on the residents and their families. So the concern that we have with this bill, and I would just want to point out that there's another bill that you're going to hear today that we actually think handles the issue in a better way, which I have discussed with Delegate Young in advance of this hearing. So just please keep that in mind. But I think a few of the issues that I wanted to raise with you today is, first, this bill is very broad, meaning that it is 365 days. So it's pre-pandemic, during pandemic, hopefully post-pandemic. And at the end of the day, visitation in nursing homes and assisted living, if you take out the last year of the pandemic, is very accessible. We have requirements that put very little restrictions on visitation. So at the end of the day, you don't need an essential care worker designation for visitation because anyone, for the most part, can come in and visit for as long as they want with a resident. The issues that have really been brought up have happened because of COVID-19 and the restrictions that have been imposed during that time. But the one thing that you have to remember is that first, nursing homes are regulated by the federal government. So on March 13th, at the beginning of the pandemic, it was the CMS that actually shut down visitation through a directive. That directive was then adopted by the Maryland Department of Health. And I can tell you, from March 13th until just last week, visitation has been dictated. Can I continue?
Finish up, yes.
Visitation has been dictated by CMS and the health department. And it has been very restrictive at times. And in order to have visitation, there has been metrics that have to be met. So for example, on March 13th, CMS basically prohibited all visitation except for compassionate care, but that appeared to be limited to only end of life care. Then the health department, through guidance from CMS, allowed in June for reopenings. But in order to reopen for visitation, that community had to be infection-free for 42 days. And that also included allowing residents to be able to use communal dining. And what has been most frustrating through this entire pandemic is that CMS and the CDC actually, they classify an outbreak as one case. So one case in a building will shut down visitation. So during the summer, when they were allowing it to reopen in June, it would shut it down for another 42 days. So we had situations where we had a part-time dishwasher who shut down visitation. The health department
we're going to have to ask you to wrap up, and I'm sure there are going to be some questions so that you'll have a chance to give more information.
Thank you. So basically, the concern that we have is much of this directives is placed on the nursing facilities. And just to answer Delegate Szeliga's question about having basically a waiver, we're just simply not allowed. It's not part of the requirements that we have to follow under CMS and the health department. And so that's the main concern that we have, is that with this bill also, it does put the onus on the nursing homes and the assisted livings to develop policies and procedures that has to come from public health experts, which is how the other bill that you'll hear later on today does handle it. So I would be happy to answer all your questions.
Thank you for your testimony. So I am looking for questions from the committee. Delegate Kelly.
Thank you, Madam Chairman. So, and I see Delegate Schlega has her hand up too, so I know we'll get back to her question again. But I just wanted to give you, Dana, I guess an opportunity to tell us a little bit more about both, how you see this working out. So there's another bill that potentially puts the onus where it should be in terms of the public health space making these determinations. So can you just finish the sentence that you were ending your testimony with? And then also, if there's anything else that you would like to add that you think is relevant for the committee in terms of, during the interim, it's just been extremely burdensome, on the industry and the challenges they faced with the different orders and anything else you wanted to say very briefly on that, because I think it's such an important point.
Thank you very much. So just to let you know, there's been basically 5 orders that have at times restricted visitation and then lessened those restrictions as the community spread has either increased or reduced. The last order came out actually last week. I think it was February 11th, and it'll take effect on March 1st. And that order does now allow for visitation to indoor visitation to continue or to start up again, but it's based on county positivity rates that are determined by CDC. So as long as your county positivity rate is basically between 0 and 10%, you can have indoor visitation. If it rises above 10%, then indoor visitation is again restricted. But the biggest issue that we are still going to be grappling as we continue through this pandemic is the fact that if there is just one case, whether or not it's a resident or a staff member, visitation must be ceased for 14 days, and it has to have 14 days of negative test of all residents and staff. So that is something that we're going to continue to have to deal with, and that is why it's so important, again, to get the community spread down, because as you saw in the last surge in December, cases, I think everywhere in Maryland, the county positivity rate was above 10%. So visitation was again shut down.
Thank you.
Thank you. Delegate Schlega.
Thanks, Madam Chair. And Dana, thank you. I first want to thank you and HFAM for everything you've done over this pandemic. I mean, if there's one area that's been so challenging, it's nursing homes and, trying to care for this vulnerable population. So I know you guys have gone above and beyond, and I just want to personally thank you for that. But how can we fix this? I mean, and I agree, this doesn't need to be codified for all of eternity, but until we can foreseeably get through this, do we need to write a letter to the CDC? Do we need to write a letter to the Department of Health? I mean, how can we liberalize this in some way?
Great question, great point. And I think, unfortunately, it really does have to start with the CDC, because it is the CDC that defines an outbreak as one case. I mean, I know that one of our members and Lifespan this summer almost did a white paper. I actually shared it with a few of you to try to allow additional visitation or to change that standard, because it seems to us that 3 or more cases should be an outbreak, not one case, especially when you consider the size of these communities. And more importantly, it should also depend on where that person is and who they have had interactions with. I mean, I feel like I'm beating a dead horse here, but a dishwasher who has no interaction with care staff or residents shouldn't prohibit visitation for 14 days. Most of the communities no longer have staff go into different, they've tried to keep their staff separate, kind of in groups. So one staff member who becomes positive shouldn't affect another building as well when there's been no interaction. But again, those are requirements from the CDC or guidelines from the CDC. So yes, I would hope as we continue to receive vaccinations and the community spread lessens, that we can lessen some of these requirements that we have been basically stuck under.
Thank you.
Thank you. Delegate Lewis. Delegate Lewis.
There we go. Thank you,
There we
Madam
go.
Chair. Thank you so much, Madam Chair. Thank you to the sponsor for the bill and to Ms. Kaufman for your feedback. I'm curious. I also experienced an elderly parent in a nursing home, and I know some of the frustrations firsthand that Delegate Lewis Young described. It's really distressing sometimes. But my question for you is, Ms. Kaufman, what's the harm in creating a kind of special category for as long as we're in this pandemic, as long as we're under emergency orders, creating a special arrangement for essential caregivers? What's the harm?
Well, I don't want to jump ahead because there's another bill that's being heard later this afternoon that does have categories or definitions for personal care visitors and compassionate care. But that bill requires that the health department do the rules and regulations and the guidance for that, which we think is a better alternative than the nursing facilities taking that on. That really, in a pandemic, should be the role of public health officials.
Okay, thanks for your answer.
Delegate Lewis Young.
Thank you, Madam Chair. I believe Ms. Kaufman said in her testimony that one of her problems with the bill is that it addresses an emergency situation. And when this emergency situation that we're experiencing is over, it wouldn't necessarily be relevant. But given the fact that we've had 3 pandemics in the past century, we've now discovered all kinds of new variants of this coronavirus, which is extending it, and rapid climate change could create more. Don't you think there's a possibility that health emergencies could become the new norm? And therefore, this would be relevant as emergency in an ongoing situation.
Well, first, I'd like to say I really hope that this does not become the norm for all of our sakes. But, you raise a very interesting point because, even through this pandemic, from the beginning till now, we have learned so much about COVID-19 and how it is transmitted and what you need to do to protect yourself. It's very hard for me to say that in the next pandemic, knocking on wood, that these provisions would be appropriate to address that situation. And I think that is just a struggle that we have. But the point that I wanted to make is when we don't have a declared public health emergency, visitation is very much open to the public. And it is a rare occurrence that visitation is prohibited. So that was my point, that non-pandemic, you don't need this bill, but it's hard to decide that what would be appropriate in this pandemic may not be appropriate in future pandemics. We just don't know, just like we are continuing to still learn about COVID-19.
Thank you for that clarification.
And our last question is from Delegate Krebs.
Thank you, Madam Chair. And Dan, I look forward to this other bill that you're talking about later today, because I truly believe that this issue is one of the most important issues that this committee can take up in this session of anything that we do. But one of my questions, we keep talking about the CMS guidelines. We keep sort of blaming the CMS, and I have a situation of in assisted living. You can't even take someone out of the assisted living, even though they've had a shot. You've had shots. You can't even take them out unless they're going to a doctor visit, and you have to bring them immediately home. So it's not getting any better. in my opinion. It's still very restrictive, but the CMS guidelines, we've been told by the CMS, and I've contacted them, they are guidelines. They are not law, they're not directives. So how do we get, I mean, all of these, we always say CDS this or CMS this, CMS that. How do we, like they say, they're guidelines. And if you followed all the guidelines, you'd never be able to do anything. So how do we get through that and give the state or our Department of Health the flexibility to do some common sense guidelines? Because as you know, everyone's now been inoculated, all the nursing home folks who wanted the inoculation, and they're still shut down in the assisted living. So how do we go back and look and say, this is a guide, this is guidance, it is not directive. So how do we find the balance there?
And you've raised a really good point that I've actually raised through this pandemic as we've tried to understand these issues and the ever-changing guidance that has come out. But the Maryland Department of Health has adopted as a requirement the CMS guidelines. But I will also say that it gets very confusing when you read, because sometimes they use the term should, sometimes they use the term required. So when I've actually had those discussions with the health department, I have been told that they are requirements. So that if the health department were to lessen those requirements, the nursing homes would still be subjected to citations and deficiencies for not following the CMS requirements. So it really has become frustrating to try to figure out really what is meant by guidance and requirements because of the way the wording has been done and the interpretation. But I have always been told by the health department, who again adopted these in their own directives, that it is a requirement by CMS.
That we should look at. And when I read these CMS guidelines, most of them shall consider. So I guess we need to look at the specific ones for the nursing homes. But thank you.
Thank you. Seeing no further questions, that concludes the bill hearing on 806. And thank you all for coming to testify today. And we will move to House Bill 652, Delegate Shi. This is Facilities, Residential Services Agencies, Guidance and Reporting.
Good afternoon. Thank you, Madam Chair. Very pleased to be here back at HGO. I am Delegate Lily Chi, here to present HB 652. This bill is about helping the private home care agencies, known as Residential Service Agencies or RSAs, that receive the state's Medicaid reimbursement dollars to comply with the state's labor laws through proactive communication and data collection. Specifically, this bill requires the Office of the Attorney General to produce a simple, no more than 3 pages long guidance document that explains proper worker classification under the current Maryland law, which will be provided to these RSAs through the Maryland Department of Health. The RSA must certify through the signature of its representative that it understands the requirements as a condition for licensure or license renewal. It also requires these RSAs to report how they are currently classifying each of their workers, either as an employee or as a contractor, and the hourly pay rate. So basically, this bill simply seeks to clarify expectations and shine a spotlight on this important issue. So why is this bill needed? We all know that home care workers are frontline employees who are among the most vulnerable of all workers. They take care of the sick and the elderly. These workers are overwhelmingly women of color. Many are immigrants and work in low-wage jobs. Worker classification makes a big difference in how they are compensated and what benefits they are entitled to, including workers' comp, unemployment insurance, overtime pay, and a reimbursement for travel between homes to provide care. Misclassification happens often and can lead to loss of wages and benefits because those classified as contractors have to pay everything themselves. This is a sensible bill that seeks to protect those workers while making sure companies receiving the state's Medicaid reimbursement dollars are doing what's required by our current law, by allowing them to make self-corrections if they are not currently in compliance. There is no fiscal note to the state, and I'm very pleased to report that the bill's Senate cross-file has received unanimous support from the Finance Committee. And with that, I will turn to my witnesses. Thank you.
Thank you, Delegate Shi. I'm going to turn to David Rodwin.
Thank you. Good afternoon, Madam Chairman, Madam Vice Chair, members of the committee. My name is David Rodwin. I'm an attorney at the Public Justice Center, where I focus on issues faced by Maryland's home care workers. And I'm also the Vice Chair of the board of the Maryland Regional Direct Services Collaborative, which brings together peoples and organizations to build a direct care workforce to meet our state's growing need for it. First, I just want to thank Delegate Chi for introducing this bill, which would improve the lives of so many Maryland personal care aides. As Delegate Chi mentioned, there's two classifications of workers, employees and independent contractors, and there's a lot of confusion amongst both the employer community and workers about what the differences are between the two. The basic difference is that independent contractors are in business for themselves, while employees work for a business. The practical consequences are extremely serious because independent contractors have all sorts of responsibilities and obligations, like paying their own Social Security and Medicare taxes that employees don't have. Independent contractors have a much harder time getting workers' compensation or unemployment insurance than employees do, for example. With this workforce, it's really a major problem. And what this bill does is it takes a pretty light approach towards addressing it. All the enforcement provisions that were in last year's version of the bill have been removed in an effort to compromise sort of right out the gate, which also reduced the fiscal note to 0. The guidance part is really about getting accurate information to the RSAs that employ these workers, because a lot rely on word of mouth when setting up their pay practices. The reporting part is really simple. There's already a system for Medicaid funded care, and it applies only to Medicaid funded care. What this does is it just has these Medicaid funded agencies report workers' pay rates and classification only. It's quite simple. It's just a one-time thing. It's not an ongoing thing like in the prevailing wage law or anything like that. And so on behalf of the Public Justice Center, we ask for a favorable report. Also happy to try to answer any questions the committee has.
Thank you, Mr. Rodwin. Ms. Denise Vaughn.
After several emails, Ms. Vaughn is not with us.
Okay, thank you, Melissa. Mr. Michael Bullis. Mr. Bullis?
Yeah, hello.
There we go. We can hear you.
Do you need, whoops. Is my video on?
Your video is not on.
All right, hang on. Whoops. There we go. Let's get that. There we go.
There we go.
Thank you so much, Chair and members of the committee. I'm the executive director of the Image Center of Maryland. We're a center for independent living, and there are 7 centers throughout Maryland. One of our primary focuses is on helping people with significant disabilities who need a nursing level of care, but who live in the community, helping them live independently in the community. And I can tell you it is tragic to watch what happens when they go through 4 or 5 and 6 caregivers in a year, simply because the caregivers are unstable, have low wages, and are unable to maintain their employment. So we are really strongly in favor of these caregivers being employees, which is what they actually are. The sad truth is a lot of employers apparently want to save money, so they misclassify people as contractors. As somebody who's been in business for myself for 40 years, I got over that issue 39 years ago. You just treat them as employees, give them the respect that they deserve. These folks deserve to be treated as employees. And so I think that's really all I really need or want to say to the committee, but thank you. And I'm hopeful that you'll give this bill a favorable report.
Thank you, Mr. Boas. Tammy Bresnahan.
Hi, good afternoon, Madam Chair and members of the Health and Government Operations Committee. My name is Tammy Bresnahan. I'm the Director of Advocacy for AARP Maryland. We are Maryland's largest advocacy group for people over 50. We have about 900,000 members. AARP Maryland overwhelmingly supports House Bill 652. We thank the delegate for bringing it forward. We worked on this last year. We've also worked with David Rodwin in the collaborative. And you might say, why? Our founder, Ethel Percy Andress, was a retired school principal, and she went to visit a colleague who had retired and found that that person was living in deplorable conditions. And she said way back then that what we do for all. And I kind of view my advocacy work as what I do for all, no matter where they are or how they live. And residential service agencies provide a very critical piece in the long-term care spectrum. And they take care of our most vulnerable adults. We just can't warehouse these folks. We need to make sure that they're being cared for by the most important people, and that those folks are critical, that they understand what their job is, and when they go into people's homes, that they are providing the care that they need. And if something happens to them, that doesn't fall back on the person that they're caring for. That's critical, because if you don't understand your status and you don't understand what is expected of you, then nobody understands what their role is. So we really encourage the committee to look at this. It's a reporting requirement, and it will let us look at how these employees are being treated, and to make sure that we are making sure that people are classified in the correct way. We ask for a favorable report. Thank you.
Thank you. Alex Beresin. Mr. Beresin?
Yes, sorry, I was on mute. Good afternoon, members of the House Health and Government Operations Committee. Thanks so much for allowing me to testify in support of this House Bill 652. I'm probably coming from the agency side. I'm probably an unusual individual to testify, but I'm a big advocate for our employees. Again, my name is Alex Beresin. I serve as the CEO of Complete Home Care. We are an RSA, the Residential Services Agency, licensed in the state of Maryland. We hire staff, and the purpose of that staff is to take care of clients, which, as mentioned many times before, includes individuals that are vulnerable, homebound, and in need of assistance. And these staff members are an important asset to the lives of those clients and an important asset to the agency to continue the business. These home care workers do not have a solid understanding of employee classification, or rather misclassification, and the benefits that they lose if they're classified as a contractor. And unfortunately, many agencies, for competition purposes, utilize this pay rate tactic as a marketing tool to draw this caregiver staff in. Little do they know the difference between being paid as a contractor versus an employee. And the agency avoids paying different taxes, workers' compensation insurance, unemployment insurance, overtime pay, and even sometimes general and professional liability insurances, as sometimes they're based off of employee pay. Contractor loses these benefits, which, especially in this time during this pandemic, they're crucial. How many people are getting unemployed, or unfortunately the sick are getting older and passing away, and these individuals are losing some of these benefits. Most states already have specific laws prohibiting agencies misclassifying their caregivers. Unfortunately, Maryland, Medicaid specifically does not. This is not burdensome whatsoever for us, as we report time in the ISAS system, which is the Medicaid in-home supports assurance system. So it would just be a simple reporting tool. So I asked for a favorable report on House Bill 652.
Thank you very much for your testimony, and to all the panelists. I will open the floor to questions from the committee. Do we have questions from the committee? Delegate Salega.
Thank you, Madam Chair. So to the sponsor, Delegate Shi, this is only about Medicaid reimbursement.
Correct. Only applying to those companies that receive the state's Medicaid reimbursement dollars.
So is that paid? Is there a certain amount for that? So see this increasing wages for employees? Is that what you're thinking?
I'm trying to understand your question.
So your bill, you want to, it sounds like what you're trying to do with your panel is provide better payment for the residential service employees, RSA employees. Is that right? Or contractors?
I wouldn't narrowly define the just better payment. I think proper classification comes with proper payment of what an employee is entitled to that is currently stipulated by the law and other benefits. So yes, proper payment will come with that, but it's not just about improving payments.
So if it's a capitated amount of money, I'm not sure that you're going to be able to get there. And finally, the hourly pay rate of the personal care aide, why do you think they should collect that information?
Because the current law says that companies should classify people as employees, but we know in practice, some don't, and we don't know what we don't know, which is why we want to start with data collection by shining a spotlight on that, by reminding people that if they receive public dollars, this is how they should classify their workers. So we're not assuming people are not following the law. We need to collect the data in order to know.
I'm not sure they have to be employees. They could, if they follow the ABC rule, they could be a subcontractor if they work for other people. So the assumption that they have to be employees, I would contend is not correct. Thank you.
Thank you, Delegate. Delegate Lewis.
Thank you, Madam Chair. Thank you, Delegate Chief, for this bill. I think it's a great idea, having, again, experienced what residential, nursing home, assisted livings are like and how the workers are frequently treated. My question for you and whoever's best positioned to answer, you referred in passing to wage theft, and I know that misclassification of workers is one thing. Wage theft is something else. And I wondered if you could go back and explain why you refer to that. How is that relevant to this bill, if at all?
Yeah, thank you for the question. I know wage theft is an issue, but again, in my previous response to the other delegate, we don't have enough data to know to what extent that is happening. By simply not classifying people properly, you could get away with not paying certain things that you as an employer should be paying, such as your portion of Social Security benefits and unemployment insurance and other things. So that's another form of essentially not shouldering your part of the responsibility, in addition to shortchanging the people's in wages.
Right. And just a quick related follow-up to that. The bill just refers to a report, but as I understood it, the enforcement mechanisms in the previous version have been removed. So is there a requirement to even deliver the report? And if so, can it be acted on? If it, depending on what's found, it could be perfectly fine, or there could be issues. What could come of a report without enforcement teeth?
Yeah, this is a great question.
Your mic is going in and out.
Okay. Yeah.
Sorry.
We thought this is a sensible first step because last year's bill, I don't know if you're aware, but one of your members, Delegate Hill, actually introduced a different version. Last year's version actually went to Economic Matters Committee, and because it had strong compliance enforcement component, it was not voted out of the committee. And we thought we would take the first step and admitting what we don't know, which is we don't know to what extent the problem actually exists. Maybe people are being properly classified, by simply requiring a very simple reporting mechanism, which is not going to be strenuous, not going to be burdensome. It's just 2 more columns in what they are already reporting. As my other witnesses can show you, it's technically very easy to do. Then we can be smarter in our policy making and enforcement. Even with this bill, in its current status as written, if you look at the letter of information from the Department of Health, it claims that because of the pandemic, it cannot even enforce that, which I don't accept. I mean, people are paid, our state employees are paid to do their jobs. They can do a lot of things. And if it's required by law, why can't we just at least do the minimum to understand, what the current practice is?
Thank you so much. Thank you, Madam Chair.
Thank you. Delegate Hill.
Thank you, Madam Chair. And thank you, Delegate Chief, for bringing this bill. I wanted to ask Mr. Rodwin to help us to understand how sometime, or maybe I'm wrong about this, but isn't it true that sometimes the misclassification is because the employer doesn't understand how they're to classify, that they don't just get to choose whether someone is an employee or a contractor, but there are actually regulations and laws that dictate how they're to be classified. So that and if that's true, doesn't this reporting mechanism help to educate them so that they don't find themselves getting into trouble as well?
That's exactly right. There's a lot of agencies that when they're setting up their practices, they just rely on what someone told them. There's a lot of misinformation out there. Some of them use this, what they call an independent contractor agreement, which is like a one-page contract that says, I agree to be an independent contractor. And they believe that if the worker signs that, that makes them an independent contractor. Every court in the country would reject the legal enforceability of that document. You can't just sign away your rights to be an employee. It doesn't work that way. But a lot of these agencies, because they're just relying on what someone told them, think that it does work that way. And it harms the workers who lose out on all this stuff. It harms the consumers. And so this bill, it takes what I think is a pretty light approach. There's no affirmative enforcement. It's just, let's educate the agencies by explaining the law to them in plain language in a short document. And then let's just to sort of encourage them to follow it. Let's have them report to the state what the workers' classifications are and the pay rate, which is just, it's a pretty gentle way of saying, hey, we're sort of watching what you're doing. We're not going to take any affirmative enforcement, but we're just sort of watching what you're doing and just sort of a gentle sort of nudge to encourage you to follow the law in a pretty, I think, economically, efficient sort of way. The fiscal note's $0. It's just, let's explain you what the law is and let's have you report what you're doing. And in that way, just encourage you to follow existing law.
Thank you.
Thank you.
And I just want to add that this bill it's a cross-file Senate version was voted out with unanimous bipartisan support. We're not assuming the worst of the RSAs who might be currently misclassifying people. And to Delegate Shalaika's point, I think what you were referring to is the fact that Maryland Medicaid reimbursement dollars are pretty low. And we are sensitive to the fact that some of them just cannot pass that cost on to their customers who have to pay with Medicaid dollars. So we start with this assumption that we just need to let people know this is the expectation. And maybe at the end, we just need to improve the state's reimbursement as part of the solution. And that could well be the direction to go,
Delegate, I just want to alert the committee staff that my internet connection is unstable. So if I go out for some reason, I'd ask for someone to pick up the meeting from that point. Delegate Saab.
Excuse me, Madam Chair. Madam Chairman, I have the same internet access. So let's pick
Yes,
someone.
Chairman.
Hi, thank you, Madam Chairman. Since I have the same internet access you have at the moment, I'm going to suggest that we have Delegate Kelly cover if something goes wrong. Okay?
Sounds good.
Thank you.
Thank you, Delegate Kelly. Thank you, Madam Chairman. Delegate Saab.
Thank you, Madam Chairman. So I guess my struggle, as an employer, usually the IRS is a good watchdog to make sure that people are paying the payroll tax and the classification between 1099 versus W-2 employees. Now, there are some benefits to have both. It depends on the employee's situation. But usually, a lot of those workers that work in, as a residential services are classified in some cases at 1099 because they hold other jobs and they call them PRNs. So I'm not sure, is this bill, what are we trying to fix? I know we don't know what we don't know, but do we have a recorded problem? Because like I said, the IRS is pretty strict on classification of employees, who's considered a 1099, who's considered a W-2, and it all depends on the relationship between the employee and the employer. If you're my employee and I tell you that you have to come to my place, work those hours, use my equipment, you're automatically classified as a W-2 employee. If you are, let's say, a teleworker, or you work at your own time, or you give me certain shifts a week, then you could be classified as 1099. So I guess my question is, if the IRS is the watchdog over this, what are we trying to fix in this bill?
So I'm going to start answering, and I would like to refer to one of my witnesses, David Rodman, to give you
Delegate Chi, we have a policy here in HGO that who can answer. So if you'd like to designate the person, please let us know who you think was the best person to answer Delegate Saab's question.
All right, then David, would you like to jump on that? Thank you.
Sure. Thank you, Delegate. One issue that question brings up is that the way that different statutes define the terms can be different based on statute. So what I mean by that is that the IRS has one definition of employee and independent contractor. And because the purpose of the tax code is just to determine who pays how much taxes, it's a little bit more permissive in terms of who it allows to be an independent contractor. When you have employee protection laws like wage laws, workers' compensation, unemployment, they have a different definition of employee and independent contractor that's more favorable towards a conclusion that the worker is an employee. So in some circumstances, you could actually have the same worker doing the same work be considered an independent contractor under the tax code and an employee under the wage laws, and not just Maryland's wage laws, but the federal Fair Labor Standards Act has the same definition as Maryland. So because it's a little bit confusing and I think not intuitive to people that you could have a term that's different based on the law, I think there's a real need for the guidance document, and there is sort of universal agreement here. I'm glad that MINCA, the Maryland National Capital Home Care Association, supports that part of the bill, the guidance part, because I think they agree that it's important to get accurate information to the RSAs. And the only disagreement, to the extent it exists, is just whether or not to include the reporting requirements. And we think that's important because the state should want to know how its money is being spent, and it's just sort of a gentle tool to encourage compliance. But in terms of a worker, even if they work for multiple agencies and they might be PRN, as you said, which means they're working as needed, pro re nata, I think it means. They still, under the wage laws, would be an employee in most circumstances in this industry, according to the case law. So it's just sort of dependent on the situation, which I think sort of calls to the fore the need for a guidance document to be brought to this industry.
Thank you. Thank you, Madam Chairman.
Thank you, Delegate. Seeing no further questions from the committee, I have two individuals who are favorable with amendments. So Mr. Mark Bain.
Hi. Well, thank you, Madam Chair, members of the committee, and thank you for letting me testify today in favor of House Bill 652. And I do have an addendum I'd like to share. My name is Dr. Mark Bain, and I am the co-owner of Comprehensive Nursing Services. We are a licensed RSA, and we are also accredited by the Joint Commission and have been in business in the state of Maryland for over 33 years. I think this misclassification affects four different groups. One is the client themselves. They are not exactly sure whether their workers have workman's comp or malpractice. So if an employee should hurt themselves in their home, would the client be responsible, or if there would be a mishap, who does the client or the patient go after if there is no malpractice insurance? Secondly, the employee. I have had several employees come to me that have been in tax trouble, and we hire them because we do take their taxes out, and then we're taking part of their salary out to pay back the IRS. They also are, again, not subject to having unemployment. If they lost their job, they could not collect unemployment. If they hurt themselves, they may not have workman's comp, and of course, no malpractice. Thirdly, the agencies like ourselves who do pay FICA, federal and state unemployment, workman's comp, medical malpractice, time and a half, and healthcare are subject to these additional fees that 1099 companies are not subject to. And lastly, the state of Maryland. You know, my company paid over $10,000 in Maryland unemployment tax last year that these 1099 companies are not being subject to. My addendum is very, very brief. It also is something I've been working on for several decades. RNs and LPNs are under exactly the same labor laws as the nursing assistants. And in all the areas that I mentioned, clients, employees, agencies in the state of Maryland would affect the RNs and LPNs as well. Thank you for letting me testify.
Thank you, Dr. Bain. Dana Kaufman?
Sorry. Thank you for the record. For the record, my name is Dan Hoffman. I'm here on behalf of the Maryland National Capital Home Care Association. We're in support with an amendment. And I do just want to emphasize a few points that were made earlier. First, current law in Maryland does allow RSAs to contract with both employees and independent contractors. There seemed to be some confusion about that, but Maryland law does allow both. And as far as a misclassification, there are penalties for agencies or any employer who misclassifies under Maryland law. I noticed it is in your fiscal note, but it is $5,000 per individual, plus, of course, all the back taxes and penalties that would accrue. So if there is a misclassification, there is already penalties and enforcement issues on the books. So I think that's a very important part. As far as the guidance document, we are supportive of the guidance document. We think it is a good first step to make sure that individuals, businesses are complying with the classification and, more importantly, understand the classification. And as part of that classification, there does have to be somebody from the agency signing it to make sure that they have read and understood. So that is a portion that I wanted to bring to your attention. But as far as the reporting requirement, we do oppose and we would ask that that be stricken. I do find it interesting that even though it is Medicaid, there are other types of healthcare providers that use independent contractors. But to the best of my knowledge, except for those few that do cost-based settlements, RSAs would be the only agency or healthcare provider under Medicaid that would be required to report the classification, but also the pay rates for their employees in Medicaid. That is not done, in my understanding, by other healthcare providers who accept Medicaid. So we would ask that that be taken out of this bill. We don't really understand it since there is additional enforcement for misclassification. And I do want to thank the recognition that Medicaid reimbursement is extremely low. The state in 2018 did their own report showing how low it was for RSAs. And unfortunately, there was supposed to be a plan to try to reduce or to equalize the cost of care and the reimbursement, and that has not been done yet. So again, we support the guidance document, but we ask that the reporting be removed. Thank you.
Thank you, Ms. Kaufman. Are there any questions from the committee? Questions? So Dana, I have a question. On the reporting piece, I understand that this is sort of unique. Is there a worry of competition? Is there a worry of burden on the agency? Because what I understand the bill to be doing is to gathering information so that we can make an assessment of whether or not this is a significant problem. I understand there's enforcement pieces, but if we don't know how serious the problem is, we don't know whether or not it's being enforced, or Folks might not even know, as we've heard from several witnesses, employers might not even know about these issues. And if the employees or contractors don't know, then these may be getting missed. So I guess my question is, what's the downside to gathering that information that's already being gathered and putting it into a report regarding hourly rate and classification?
Well, I think it's a combination. One, it is not being gathered already, except for the RSA, just like any other employer has their pay rates. But I think it's a combination of, we keep hearing it's an easy report, but if you look at the language in the bill, the actual language doesn't say how the report would need to be made or even the frequency of the report being made. So that's one issue. The other issue would be, yes, we do think that it is another administrative burden to be putting on these RSAs, but also, again, these are private businesses. They may take Medicaid dollars, but you don't have other private businesses that accept Medicaid reporting what their employees' individual pay rates are. So it is unprecedented. And we think the better way to handle this issue, if there is concern about misclassification, is to provide the guidance document and try to educate to make sure that there is not misclassification. And again, there's always the opportunity for the Department of Labor to come in and on a complaint or any other time to determine if there is a misclassification and then to do the enforcement penalties.
Thank you. That's very helpful. Are there other questions from the committee? Seeing no further questions, that completes the work on HB 652. And we are now at the point where the committee will take a 32-minute break. We will reconvene at 3:45. Please don't go too far away, but we'll see you back here at 3:45 to continue the hearings. Thank you. Wait. Let's see. Excellent. Hello, Delegate Lehman. Welcome to HGO. You're on mute.
Thank you, Delegate Cullis. You're chairing the committee today.
That seems to be my role. Yep.
Okay, so it's appropriate to refer to you as Madam Chair. I'm glad that.
We're going to start in about 2 minutes, but we are starting with your bill. So.
Okay. Thank you. Madam Chair, I don't know if you need to know, but I have timed my testimony. I should be just about 3 minutes, and I would like to take advantage of the committee's rule to cede the extra 2 minutes of my time to 2 of my witnesses.
Can you do it to one of your witnesses?
I can only give it to one witness?
Generally, that's how we've been doing it, right?
Okay.
So
okay, that will be challenging for both of them, I think, but okay.
Dana or Mary?
I should have 2 other witnesses, not Dana or Mary, but the 2 other witnesses on my panel. One is Ellen O'Brien.
She's favorable with amendments. You want her to speak after you?
Yes,
Okay.
Ellen, yes. And then the other one would be Twyla Bridges. Is she? I know she signed up. I hope she's.
Yes, she signed up. Yep.
Yeah,
So,
I was hoping to give them each 3 minutes, and I would take 3 minutes.
we have.
Unless that's too complicated.
So yeah, well, just see, they might be faster than you, one of them might be faster than you think, so.
Okay, okay,
We'll see.
okay. Thank you.
Okay, we are, Melissa, we're streaming, correct?
Yes, we are.
Okay, then we should get started. Welcome back to the Health and Government Operations Committee. I know you were privy to a little prep for this next bill. It is House Bill 983, Delegate Lehman, and it's nursing homes, COVID-19 visitation. And we're going to start with the sponsor, Delegate Lehman.
Thank you so much. Good afternoon, Madam Chair, Madam Vice Chair, and committee members. For the record, I am Delegate Mary Lehman, asking for your favorable report of House Bill 983, requiring nursing homes to allow compassionate care visits by designated family members or guardians during COVID-19 and future catastrophic health emergencies declared by the governor. This is a story about thousands of nursing home residents in Maryland and across the nation who have been physically and emotionally cut off from family members and friends for almost a year because of COVID. My own 88-year-old mother is one of those people. She's a resident of a nursing home in Montgomery County, and my family has watched through a window as she has become less and less interested and engaged, and more recently, clinically depressed. Window and Zoom visits with elderly people are just not the same. Family members and to be able to interact in person. At the same time, we have been unable to talk to mom in person and do the things she loves, like look at family photos, read our hometown paper, the Greenbelt News Review.
Delegate, I'm sorry to interrupt you, but someone is not muted and they have something streaming on YouTube, so we're not able to hear you. Please mute yourself if you are not speaking now. Thank you, Delegate. Go ahead.
Okay. We have not been able to interact in person and do the things that mom loves, like look at family photos, read our hometown paper, the Greenbelt News Review, and do crossword puzzles. At the same time, the nursing home social activities and programs have been severely curtailed. There is nothing for her and other residents to look forward to. We recently requested a psychiatric evaluation of my mother. The doctor confirmed she was clinically depressed as a result of social isolation. The doctor said she would not benefit from an adjustment to her antidepressant medication. Instead, he ordered 3 to 4 one-hour visits a week by a compassionate caregiver. Those visits began recently and they have helped her. We have to pay out of pocket for those, which is fine. However, not every family can afford to do that. Our view is if a screened outside caregiver is permitted to provide emotional support to a nursing home resident, then a screened family member should be able to safely do so. So House Bill 983 instructs the Department of Health to develop visitation guidelines that require a nursing home to allow visitation by a compassionate caregiver, restrict the visitor to the resident's room or another designated room, and require each visitor to follow safety protocols such as COVID testing, temperature screening, and use of PPE. The guidelines also establish procedures for designating just one personal care visitor per resident, changing that visitor, and establishing when visitation may be suspended. Madam Chair, this is a carefully crafted bill that addresses the devastating mental health effects of the isolation of nursing home residents as a result of COVID. It has safeguards to prevent the spread of COVID, and it waives liability for nursing homes in case a visitor becomes infected. I have an amendment that expands the bill beyond COVID-19 to cover future catastrophic health emergencies declared by the governor. Today, members may have started receiving emails saying that this bill would unnecessarily restrict nursing home visits. I hope I've explained it in a way that you understand it will do just the opposite. I'm grateful for my panel that has come to support the bill with their compelling stories, and I thank you and urge a favorable report.
Thank you, Delegate. And we're going to move to Ellen O'Brien, who will be able to have the remainder of the delegate's time. Is Ellen here?
She should be in the room.
Ellen O'Brien? Maybe
I'm here.
Ah, there you go. Okay.
Okay. I'm a Maryland resident since 1993. I'm a middle child of 9 kids raised in Michigan. And my very first job was in a nursing home where I actually took care of Jimmy Hoffa's mother, believe it or not. Anyways, I worked then in a hospital in North Carolina, and until my father's death. And he was murdered. And at that time, I dropped out of college, and my mother actually started going to college at that time, and she got a degree in gerontology to try to make sense out of my father's murder. And needless to say, the subject of dignity of death and aging was often a conversation among her 9 children, and it was a bond that grew us all closer. But one of the things she really taught us was that you needed an advocate, and that's what this bill 983 does. Is that the right number? Anyways, later on, I took care of my mother-in-law. I shopped nursing homes in Pikesville. She was there for 5 years. And then my mom in Michigan was there in a nursing home for 10 years. And it was in that time that that she caught COVID last year, or even prior to COVID. She got shut down. She was isolated, and you might have seen, there were lots of media clips about it that ended up being on ABC World News Tonight. And it made it this really nice feel-good story because all 9 of her kids came from all over the United States and tried to take her out of her nursing home. But we all tested negative and she tested positive. And so that we couldn't get in to see her. In 2 months' time, by the time we could see her, she had dropped 20 pounds. No, I'm sorry, 15 pounds. It was 2 months, you know. I mean, that's from depression. That's from it was just from the isolation. She was locked down. We couldn't see her. She couldn't see us. Our society uses isolation as a punishment, you know, such as solitary confinement. And that's what we were doing to these nursing home patients. And why would we want to do that? Because they already have a sense of isolation because they've left their lifelong homes and loved ones. All the patients need advocates and visitors in these homes. Otherwise, bad things can, and they do happen. I can't begin to tell you how many bad things happened that we only found out after the fact. Anyways, we have suffered with the COVID pandemic for over a year now, and we've learned a lot about protecting ourselves from this disease, such as masking, social distancing, etc. Mom was an early victim. She was deaf. She was 101. She had a lot of emotional baggage about abandonment issues earlier in her life, and isolated from view, she's just suffered. She didn't understand what happened to her large family and friends who had visited her constantly. And she was confused and happy when all her kids finally danced outside her window. And I can hear her now when we were explaining it to her. It was like, what in the world? And that was after we told her what we had to go through to be with her. It was just a battle. The nursing home was not forthcoming in information due to staff shortages because they were scared, they were getting sick and dying too. 1/3 of the patients died in her nursing home, and a nurse had died that we knew of. We didn't find this out readily. Anyways, I'm running out of time. Basically, I want you to enact this bill so I don't have to die alone. And in the meantime, I get to visit my 85-year-old cousin in Virginia who gets to be taken out of her assisted living once a week by her daughter. And why can't we do that in Maryland? It just, there's precautions you can take now. There's vaccinations. It just would make life more normal. Please watch the clips because they are pretty heartwarming that I put in my written document.
Okay. Thank you, Mr. Ryan. Twyla Bridges. Ms. Bridges?
Good afternoon. Good afternoon, Madam Chair. Madam Vice Chair, and committee members. My name is Twyla Bridges. I'm a mother and the biggest advocate for my son in memory of Joseph S. Hall Jr. I'm in favor of the House Bill HB 983, and no one should be alone in their final hours. For 40 years, 8 months, and 7 days of this time, Joseph resided in the nursing home for 24 and a half years. I overcame adversity, fear, being apprehensive, uneasy, worry, and anxiety, while at the forefront being an advocate for my son. In 1985, my son was diagnosed with a rare disorder called MPS Sanfilippo syndrome type C. This regressive disorder over time left his mental capacity functioning as a 7-month-old in the body of an adult. On March 10th, Joseph's care plan with his doctor and nursing home staff concluded his health was deteriorating, and at this point, all we could do is keep him comfortable. On March 13th, when the nursing home closed the doors because of the COVID, it shattered me. I cried and feared for Joseph. It was my youngest son who reminded me, Mom, keep the faith because you are God's fearing woman. At the point of discussion with the administrative medical director and reviewing the March 13th CMS latest update that my circumstances with my son falls under the exception for certain compassionate care situations, such as an end of life. I followed the CMS protocol for the nursing home and followed the same protocol at home. The facility COVID case started in the nursing home with the staff in April. On April the 20th, I was informed 2 residents tested positive. When I visited Joseph on the 21st that evening, I noticed he was burning up, temperature taken, x-ray, and an antibiotic was ordered. Unfortunately, on the 22nd, the x-ray results confirmed Joseph's lungs were not good compared to the previous month. His doctor ordered to send him out to the hospital 911. That evening, the hospital diagnosed Joseph positive with COVID. Hope was for my son. This was the first time I could not be by my son's bedside. Guide the doctors and nurses how to communicate and care for him since he was not able to tell his story. I sat in the hospital parking lot waiting for the emergency room staff to call me. They never did, but persistent, I called them. The next day, the hospital wanted to send Joseph back to the nursing home. They stated the 99.8 normal temp, but due to his illness, this was not a normal temp for him. It was the support I received from Delegate Penamelik, Dr. Trudy Hall, his primary care doctor, the nursing home management team. Joseph did not get discharged. My decision stand that Joseph was not stable enough to be discharged. That weekend, he struggled with his breathing. His G2 burst was not able to be replaced. As a result, no way to be fed, receive his medication, and a lot of pain, along with high temperature throughout the weekend. That Monday, the 27th, the head nurse discussed with me that Joseph's condition worsened and my DNR preference for him. He would not make it through the end of the week. During Joseph's hospital stay, the nursing staff allowed me 24/7 Zoom access at my son's bedside so that he could hear my voice, comfort him, and communicate with the staff. April the 30th, 2020, Joseph fought to the end and received his wings at 10:33 a.m. Eastern Time. I was deprived of being present at his bedside, but the last voice he heard was his mother. That I will cherish forever. I urge a favorable report.
Thank you, Ms. Bridges and Ms. O'Brien, for sharing your stories, and we're very sorry for your loss. I'd like to call Aaron Greenfield, please.
Good afternoon, Madam Chair, members of the committee. I hope you can hear me okay. This is Aaron Greenfield on behalf of Leading Age Maryland, a community of not-for-profit long-term care providers. We are here favorable with an amendment on House Bill 983. We very much appreciate the discussion we had with the sponsor and are sympathetic to the personal experiences shared by the previous panelists, as well as Delegate Lewis Young and Delegate Lehman. You know, COVID-19 has put providers in a very precarious position, following and complying with the guidelines and orders while sharing the challenges expressed by resident family members, some of which you just heard. Our amendment quite specifically requests that these MDH guidelines are consistent with those from the CMS. CMS guidelines, as you know, and as Ms. Kaufman said in an earlier hearing, are followed by nursing homes and are informed by the CDC and allows, in our opinion, the most flexibility and access and in-person protection. Without this amendment, the Department of Health guidelines could be actually more restrictive and run counter to the sponsor's intent. For those reasons, we request a favorable report with that amendment. Thank you, Madam Chair.
Thank you, Mr. Greenfield. Dana Kaufman? Dana?
Okay, here we go. Sorry about that.
There we go.
For the record, Dana Kaufman here on behalf of Lifespan Network again. I'm not going to repeat what I had previously said regarding the guidance and the directives. On this bill, the reason that we believe that this has a more workable platform is that it is limited to COVID-19. I have not seen the amendment about future pandemics or declared public health emergencies, but the fact that it's limited and the fact that the guidance that has to be issued would be done by the department and not by each individual nursing home gives us greater comfort, because we don't want to be the ones who are stepping into the role that really public health officials and epidemiologists needs to play when you're talking about a public health crisis. So we do think that this bill is more workable. I do want to say, and it's just a fact, that even with this bill, the governor's executive power will always supersede. We're not making any changes to the governor's executive authority. So it does supersede, but we would be hopeful that with this guidance, that it would be taken into great consideration moving forward, especially given the issues that you have raised and the frustration and just the health status that everyone has seen affect our nursing home residents and our family members. So thank you.
Thank you. And our last witness in support is Mary Carter.
Good afternoon, Madam Chair, Madam Vice Chair, and committee members. My name is Mary Carter. I'm an associate professor of gerontology and health sciences at Towson University, and I am pleased today to testify in support of House Bill 983. The devastation wrought by the COVID-19 pandemic has laid bare the vulnerabilities of our long-term care system for older adults, including poor quality of care, short staffing, and epidemic levels of loneliness and isolation. Although each of these problems were immediate concerns prior to the pandemic, the situation has quickly become more dire. Nursing homes have borne the brunt of the pandemic. In Maryland, roughly 45 to 55% of all COVID deaths have occurred among nursing home residents, despite representing less than 2% of our state's population. In response, outside visitation by loved ones ceased and residents were restricted to their rooms. What began as a short-term effort has become standard practice, with lockdowns still in place more than 1 year later. Now, reports of unspeakable pain, neglect, and loneliness are emerging, replacing earlier headlines of infections. Research has long documented the devastating effects of isolation and loneliness on health and well-being, and particularly for older adults, including increased risk for heart disease, stroke, depression, weight loss, dementia, and death. Recent surveys of individuals living in nursing homes reveal staggering increases in reported feelings of isolation and loneliness, with more than 3/4 of residents reporting no outside interaction since COVID. Staff shortages further erode opportunities for socialization as time for the more humane interactions between staff and residents are curtailed. Alarmingly, estimates suggest that for every 2 nursing home COVID-related deaths, a 3rd death occurs, driven in part by the loneliness and despair that residents have faced. These deaths reflect the consequences of the many personal stories heard today. Clinical depression, lack of will to eat, loneliness, isolation, dismay, neglect, and withering away. On death certificates, this is often recorded as failure to thrive. However, it's not that residents have somehow failed, but that we have failed to provide the hope. In response, we need common sense practices and nursing home policy that ensure that steps to providing safe, compassionate family visits are more mandatory for all nursing homes. Importantly, this bill provides not only that support, but it also brings the community back into the nursing home to ensure compassionate care and to provide oversight and supporting humane care for older adults. Thank you.
Thank you. Thank you all for coming to testify today. Are there questions from the committee? Delegate Bandari.
Yeah, thank you, Madam Chair. I'm really sorry for Ellen and Twyla's the loved one death, and it's very emotional hearing. And this question is to Dana. In previous bill, you testified on, it was Delegate Young's bill. You pointed out that it was because of CDC's guideline that define outbreak at one case. So how does, you said that this is more workable and you support this bill. How does that change that very metrics?
Unfortunately, it doesn't. That is always going to be an uphill battle until CMS changes that metrics or CDC changes that metrics. So that this bill does not touch upon that. I believe what the hope for this bill is that it provides some additional guidelines or guidance for Maryland nursing homes to be able to allow visitation more readily. But again, not to sound like a broken record, we still have the CMS requirements that are on nursing homes that are going to have to be followed as well. But again, to your point, the one, it's still the one. So hopefully in the future, as we learn more and we get more vaccinations, that can change.
Thank you.
Madam Chair, can I point out quickly that
Delegate, I'm sorry, we have a policy of only one answer per question. We're doing in the subcommittee, we'll be able to follow up on that. I don't see any other hands, but I have a question for Dana regarding the two amendments. Aaron's amendment in adopting the CMS standards and making this bill useful for potential emergencies. Do you have a position on either one of those, or do you need some time to, because I think you said that you really didn't know about them yet, so.
Right, well, for the consistency with CMS, unfortunately, just because nursing homes are regulated by the federal government, our hands are tied to that. So if MDH is stating, which they have to us, that CMS requirements have to be followed, then that amendment would just be consistent with the practical aspects. As far as other infectious diseases, I think it's declared public health emergencies. I would just need to take a look at that. But again, I think that the issue is always the unknown and what that next one may look like. Hopefully that this is still a situation that, again, moving forward, we recognize the heartache that has occurred through the lack of visitation.
Thank you. Vice Chairman Pena-Melnick.
Thank you, Madam Chairman, and good afternoon, Delegate Layman. This is just basically a comment. I wanted to thank Mrs. Bridges for your just tireless, fearless advocacy for your son and for the rest of the community. I'm really grateful, okay? Thank you.
Thank you. Seeing no other hands, that concludes the hearing on HB 983. Thank you all for coming to testify today. And Delegate, thank you for bringing us this bill. We will move on to House Bill 674, Delegate Valentino Smith, homes, transfer of ownership, site visits, and surveys. Delegate Valentino Smith.
Hi, members of the HGO. If I don't see if Madam Chair, Vice Chair, and Madam Esteemed Chair, Delegate Cullison. You've had a long day listening about nursing homes, and I know we have very good providers, and sometimes we have some subpar providers. We have for-profit providers and not-for-profit providers. And I'm here today in an effort to ensure quality of care in nursing homes and greater oversight when ownership changes. So I'm introducing and bringing to you House Bill 674, which requires the Maryland Department of Health's Office of Healthcare Quality, we call them OHCQ, to conduct timely and early site visits and surveys. The bill is proposed is at 1 and 3/6 months when nursing home ownership is changed and it's transferred to an entity that's out of state and has never done business in Maryland. As you're aware, there's been an uptick in outside private equity and investment in firms entering into the nursing home industry, both nationally and in Maryland. And unfortunately, this investment dynamic can create some economic incentives and models that don't always prioritize quality of care over profit. These new investment models and the experience that we've seen here and in other states has cast light on some of the operating practices by these companies and weaknesses in our own regulatory ability to monitor when there's a change in ownership. So in May 2020, we saw information from the New York Times about the number of organizations that actually are in this, and we're seeing an epidemic of it with 70% starting to be owned by private investors. And in 2008, the laws changed that allowed these realty companies to invest, and that's really created a problem for us. So in May, let me move my testimony up, sorry. I'm on faster with the clock ticking. It causes us all to reorient ourselves. Let's just switch, come to our state. In December, you probably saw a really bad Washington Post article that pointed to a New Jersey-based firm that was Porta Piccolo, and they started snatching up nursing homes in Maryland during the pandemic, and quickly started making major changes to employee benefits and quality of care, and people started leaving and quitting, and it really caused a significant article for us to realize there can be problems when people that haven't operated before in our state now come in. So it's been percolating around for a while. And in addition, there's a long-term care community coalition, and they have rated 15 states that have good oversight when these changes occur. But unfortunately, Maryland is not one of them, and that may be why these investors come into Maryland. We don't have a strong oversight system. So today, I really want to thank Tina Hurley. She's been waiting a really long time. Her mother was a resident of Porta Piccolo Nursing Home, and she's going to speak to her about her experience about what happened. We were going to hear from an SEIU nurse who worked and can talk about very directly the changes that occur, but because of the snow, she had to stay on her shift, so she won't be here. Currently, the Maryland Healthcare Commission looks at these entities, but it really only has the ability to look at capacity. As you know, they're our regulator for capacity. They look to see if you're adding capacity or changing the capacity. And they take a teeny little look at ownership and whether there's been any felony convictions or anything along those lines. But overall, they don't have broad authority to do a good quality review oversight. In working with them, working with Senator Beidel, we've worked on this bill. We believe this is the first effort, and we're going to spend some time out of session to get agreement with regulators and hopefully the providers on what more in depth we should do when oversight changes. But this puts into place after the ownership. They'll come in, they'll do a quality audit. HFAM has an amendment in where they want to change it from right away. They just want it to be at 3 and 6 months. Senator Beidel and I are going to agree. We want to have consensus with the industry. And with respect to the fiscal note, I really want to talk about the fact that the fiscal note seems to have been written on doing an audit for any transfer of ownership, and that is not what's intended. It's transfer of ownership when somebody hasn't done business in the state of Maryland. I really also want to talk about the fact that the fiscal note says they're going to need extra reviewers. I'm just going to read from you real quick. we take their audits over in appropriations. Here's what we know from the budget of OHCQ. They're getting 10 new positions this year, 4 of which will be on nursing home surveyor units. They are receiving 10 positions in fiscal year 20 and 21, with 4 or 5 of those going to fiscal units. And they're going to get another 10 positions in 2023 and 2024. So I respectfully disagree with the fiscal note and believe that they have the surveyors needed to do this. So I see that the clock has rung for my time. I'll just say I think that this is a small investment that we can make now to put some quality measures in for when somebody comes in and hasn't done business in Maryland. And then we'll come back to you with some more in-depth work on this. I don't believe there's any opposition, which is, I know, something important. And I look forward to a good report from the committee. Thank you.
Thank you, Delegate. So I'd like to call, is it Brenda Hurley or Tina Hurley? I have Brenda on my sheet. Ms. Hurley?
I hope she's still there.
Melissa, do we know?
She never showed up in the waiting room, unfortunately.
Okay. Then we'll go to Eric Colchamo.
Hello. Hopefully you can see me. I'm waiting for the clock to reset here. Great. And I just want to note, Ms. Hurley waited for multiple hours, and there may be some technical difficulties going on and just lack of understanding of the Zoom system. But as Delegate Valentino Smith said, I want to acknowledge her and the situation she went through at a Porto Piccolo facility, and say thank you to Ms. Hurley for being willing to come forward today and waiting so much time. And I do feel lousy that it doesn't seem to have worked out for her for technical difficulties. My name is Eric Colchmiro, Director of Government Affairs for the Alzheimer's Association in Maryland, and here today to ask for your support of HB 674. Over 40% of the residents in nursing homes and assisted living facilities have Alzheimer's or another form of dementia. More than 95% of those residents have another chronic condition. Their care is complicated. It's essential that all long-term care facilities have the means to provide good care for their residents. As Delegate Valentino Smith noted, Porto Piccolo bought over 20 properties in our region to make a profit. And their purchase of these long-term care facilities speaks to a systemic issue. Long-term care facilities, and especially nursing homes, are moving away from being small, family-owned businesses. In particular, real estate investment trusts like Porto Piccolo, by definition, a company that owns and in most cases operates income-producing real estate, have dramatically expanded their ownership of nursing homes in Maryland and across the United States. Yet these for-profit companies lag behind their nonprofit counterparts in the quality of care they provide. This bill puts forward a straightforward system into place. It says that the current system, where out-of-state owners have to solely fill out a disclosure form with the Maryland Healthcare Commission, is not working. We need to create a significant infrastructure for how we evaluate the business of long-term care in Maryland. This pandemic and its disproportionate impact on long-term care facilities has heightened the importance of this issue. We need MHCC to look further into the new owners of facilities that care for our greatest generation. We need OHCQ empowered to help seniors more. And we need this legislation to put a standard in place so real estate companies are not in the process of flipping nursing homes to make money. I ask for a favorable report.
Thank you. And I apologize that Ms. Hurley was not able to stay, and I know it's a long wait sometimes. So thank you for representing her. Are there questions from the committee? Okay, I see no questions.
Can you hear me? This is Miss Hurley.
Oh, yes, we can hear you.
Madam Chairman, I think Delegate Lewis Young has a question.
I know, Delegate, but Ms. Hurley has just come on, so I'd like to give her her time to speak.
Okay.
Go ahead, Ms. Hurley.
Okay, Chair Pendergrass and Vice President Penna Melnick. My name is Tina Hurley, and I I am the daughter of Brenda Middleton, who is a patient at Peak Healthcare in Denton, Maryland. After I placed my mother at Peak Healthcare, I learned that it was one of the 20 properties in our region purchased by Port Piccolo, a New Jersey-based investment firm. I'm here today to tell you the same story that I told to Washington Post in December's article they did on this company and how they buy facilities and try to make money off of people like my mother. I can share that my mother was brushed off or ignored at Peak Healthcare multiple times. My mother has a history of DVTs and factor V, and at one point her roommate fell onto my mother's leg and it created a huge hematoma. I talked to her doctor several times to send her to the hospital, but the doctor dismissed the request. Over a period of time, my mother ended up with cellulitis, major infection, and the doctor still prolonged getting her to the hospital. After a painful 6 weeks, she had to get a PICC line put into her upper chest to get antibiotics put into the bloodstream. To this day, her leg is still swollen with a lot of fluid and is discolored a deep purple. About 3 weeks ago, my mom's roommate tested positive for COVID, and in response was told to stay there in the same room, but put a mask on. Staff came into the room 3 to 4 days later and finally moved my mother out into a different room for at least 4 days, then proceeded to move her back into her old room. I am here today because the big businesses that run my mom's facilities can do a lot better for my mother, even if COVID wasn't happening. I ask for you to please support the legislation today, HB 674. I sincerely hope that writing this letter and communications in these conditions and events will not prompt any retaliation or willful neglect towards my mother.
Thank you very much, Ms. Hurley, for sticking with us today. I'm so glad that you were able to be here.
I was able to hear you all, and I kept saying, I'm here, I'm here, I'm here. You couldn't hear
And
me.
now we finally know, right? I'm going to start with Delegate Lewis Young, who has a question.
Thank you. I would like to direct my question to the sponsor of the bill. First of all, thank you for bringing this bill forward. I think it gets at the heart of some of the problems in the industry. But it's my understanding that OHCQ was supposed to update the guidelines on assisted living, or the regulations on assisted living facilities. And they postponed it while they were working on guidelines for nursing home regulations. Now, those were completed in 2019, and we're still waiting for updated regulations for assisted living. So my question is, would you be amenable to a friendly amendment that requires that within a reasonable period of time, those regulations are updated? Because for them to be doing an evaluation on outdated regulations may not get to the problem we're trying to solve.
Well, thank you, Delegate Young, for the appreciation for the bill. And I'm very respectful of the fact that once I click off the Zoom, this is the body, this is the subcommittee, and that will be up to them and not me. But I do want to say that with respect to the bill, it is requiring the audit. OHCQ can come in and audit upon any complaints. Look, we know they can do that. And we know they have to audit within a year. But what this bill is saying, when you've never done business here before, we're not going to wait for the poor patient that probably can't pick up the phone and call and tell us it's a problem or may not have family. We're going to come in and look at you under the current audit guidelines. And so I don't want to wait or, cause any delay. I thought there were more people signed up to testify, but if you look in your file, I think you'll see a lot of written support from the provider industry too, that having a look at 3 and 6 months, which the amendment takes away the first month under at least the current guidelines is needed. So thank you. I feel your frustration, but that's
Thank
a
you all.
subcommittee decision, not mine.
I'll pursue it another way. Thank you.
Thank you, delegates. Delegate Lewis.
Thank you, Madam Chair. Thank you to the bill sponsor, Delegate Valentino Smith. And I also wanted to commend Mrs. Hurley. Thank you for hanging in there, not giving up so that we could hear your testimony, ma'am. It's very important. Thank you.
You're welcome.
I'm so personally disturbed by the idea that Wrights and hedge funds are operating healthcare facilities in our state. I guess I hadn't really understood that. That I wonder if there's any appetite to be even more radical about how we approach these types of facilities. We have a situation where hedge funds are basically destroying the newspaper industry by extracting profit. And I dread the day when similar entities get their claws into, our healthcare system. I wonder, Delegate Valentino Smith, if there's any logic for looking more closely at how these right or hedge fund run facilities contribute to our total cost of care mandate. Have you thought about that?
No,
An audit might not be enough.
No, I think that Senator Bidel and I, even when we've been working on this, realized the significance of the problem with respect to the changes in law that have allowed this type of investment opportunity. And at that investment opportunity, as you can imagine, they separate themselves to a management company that runs the nursing home so that there's even more debacle in terms of the separation. And so across the nation, the articles we've been reading, it's not only a problem here across the nation. CMS and the federal government are going to have to get involved. Certainly, I've been in discussions with the Maryland Healthcare Commission about the limitations that they have in looking at quality, and we're going to have more robust discussions in the interim. I don't know that we can stop because it was federal law that allowed the investment of the real estate companies into nursing homes. But I agree with you that this is a road that looks like it's going to lead to decisions being made based on profit even more so than quality of care, with little to no accountability because of the separation in the management company and the investors.
Thank you, Madam Chair.
Thank you. Delegate Belcastro.
Thank you, Madam Chair. My question is for Mr. Colchamiro. I know that you work really closely on the assisted living regs, and I was wondering if you could elaborate on Delegate Young's question about the assisted living regs.
Great, thank you. Yeah, and this bill, I should clarify, is about nursing home regulations and is calling out the issue of real estate investment trusts. But to Delegate Lewis Young's question and the friendly amendment she was suggesting, we welcome an update to assisted living facility regulations along with Delegate Kerr, Delegate Belcastro, Senator Bidel, and Senator Eckert. We've been members of the Oversight Committee for the Quality of Care in Nursing Homes and Assisted Living Facilities. The challenge here is that assisted living facility regulations are due to be updated every 8 years. They were last updated in December 2008. The health department started a process, as Delegate Lewis Young may know, of updating them in 2015, released a second draft in 2016, and then as they had a number of things on their plate, have suspended that. And they are not due again technically until 2025. So I welcome an update to assisted living facility regulations. However, any sort of friendly amendment, I would strongly urge this committee have a end date, not a reasonable time frame, but a concrete end date. It's going to take over a year for those regulations to be updated. And if you start now, it's not going to be done until December of 2022. So it's a great point by Delegate Lewis Young, and I thank you for that. But I'd urge the committee, if they are to consider an update to assisted living facility regulations, there be a concrete end date, because we do need to move forward prioritizing and stabilizing long-term care facilities and recognizing what they've gone through with COVID, but putting concrete end dates, putting timelines in place so that we can duly protect residents. And I thank you for the opportunity to address that question.
Thank you. Delegate Hill.
Thank you, Madam Chair, and thank you, Delegate Valentino Smith, for bringing this bill and for really working on this issue, which I agree with you is it's been a problem before these investors were allowed in. We've had a lot of issues, and probably ought to do a real summer study work group kind of thing or something. But here's the question. The bill doesn't specify that these are announced or unannounced visits. And from what I've seen in the past, they're generally announced, which gives people a chance to prepare. Is that your intention?
So the regulations as they exist for the audits are supposed to be unannounced. And so I would hope that consistent with that they are unannounced. And I will tell you, we've all been around the block a lot with nursing homes and assisted living facilities. You on the policy side, me on the finance side. I have to strap a helmet on for that hearing because I bang my head on the table so much because they are so far behind in their audits for the assisted living facilities, which is why we mandated all these additional reviewers coming in. And so in response, Dr. Hill, I think it should remain, and the intention is as it currently is, unannounced.
In regulation, but you don't feel it needs to be in statute?
No, look, I think we can add that word to the statute.
Okay, thank you.
Thank you. Seeing no further questions, then that concludes the hearing on House Bill 674. Thank you all who came to testify today. Thank you, Delegate, for bringing it to us. And we will move to House Bill 810. Okay, House Bill 810 is being sponsored by Delegate Cullison. It's health occupations, pharmacies, pharmacists, laboratory tests. And I am just going to introduce the bill, and then I'm going to turn it over to my panel I'm going to turn my sponsor time over to my panel to explain the bill. And I will need to say that the bill will be heavily amended in order to match the bill in the Senate. This bill came in late in the drafting process, and we were still making some decisions when we finalized the language. Very simply, what the bill does is would allow pharmacists to order certain laboratory tests at the request of a customer and collect basic, minimally invasive samples to send to a lab. We're in challenging and changing times when it comes to healthcare. Two considerations that we as a policymaking body have and maintain is that we want to increase access to health services, and it's a priority for us. And we've also encouraged individuals to become actively engaged in preventive healthcare measures. Under this bill, people would have additional options to make informed choices about their healthcare. They would have more direct access to lab testing, which often serve as a preventive measure that they can use in conjunction with a physician. There is no intent to limit the role of medical professionals in this bill. It is simply a supplement, a tool in how a person accesses care. The advocates will explain how the laboratory testing process currently works and how it could work if there were access to these aspects of healthcare at our neighborhood pharmacy. I understand how this concept might seem perhaps a little too innovative. I would just ask you to consider the times in which we live, when increased access has become foundational to healthcare, and how this practice could provide greater awareness about healthcare needs and provide options for individuals to be even more self-determinant in their care. Thank you very much for your attention and consideration. I respectfully request a favorable report, and I designate my 5 minutes to Jonathan Cohen, please.
Thank you, Delegate Cullison. My name is Jonathan Cohen. I'm President and CEO of 2020 Gene Systems. We are a clinical lab testing company based in Rockville, Maryland. And as you'll see over my right shoulder, we are doing, as we speak, testing from nursing homes, COVID testing, that is, PCR testing from about 5 Maryland nursing homes. I think that's timely in light of the various panels this afternoon. I apologize that I'm wearing a mask But in light of the fact that we're doing COVID testing, I think that's necessary. If for some reason you can't hear me or I'm muffled, please interrupt and let me know. So a few words about what is a lab test. So lab tests are regulated both by the federal government through CMS and also through the Maryland Department of Health, heavily regulated, that is. There's over 100,000 of them. And the advantage of a lab test versus a rapid point of care test, like a home pregnancy test, is better accuracy. They're more sophisticated and they tend to be more accurate. Just like in PCR for COVID, they tend to be more accurate than the rapid antigen tests. Now, in much of the country, and actually about 22 states, consumers themselves can order a lab test without any provider ordering it for them. And 12 of those, and then an additional 12 states, in addition to the 22, permit a modest amount of tests to be ordered. Maryland is one of them. They allow just a few tests to be ordered. So this bill, I want to emphasize, is a modest, incremental advancement over what's currently being done. If consumers can order them on their own, certainly having a trusted pharmacist, they undergo a great deal of education, is probably providing more safety and oversight than the status quo. Pharmacists in Maryland are currently allowed to order a handful of tests, small number, about a half a dozen. This bill would increase that number only slightly to things that are more screening, wellness, and prevention. And in the amendments that Delegate Cullison referred to, we put some safeguards, some guardrails, if you will, so that in the event of a test that's out of range, too high, too low, that the pharmacist would notify the patient's primary care physician. So I want to emphasize that during COVID, pharmacists have played an extremely important role, not only in vaccination, as we all know, but in testing. And since April, a directive from HHS, pharmacists have been on the front lines of both swab testing and antibody testing. And that has gone very, very well. So the time is right to broaden this out, to allow Marylanders to visit a trusted pharmacist, whether it's a chain or an independent pharmacy, and get access to a variety of screening tests that are run in a regulated CLIA lab like the one that we have here in Rockville, Maryland. Thank you very much for your time this afternoon.
Thank you, Mr. Cohen. I'm going to call on Ademola R.
Oh, thank you, Madam Chair and committee members. Thank you for the opportunity to provide oral testimony in favor of House Bill 810. My name is Ademola R. I'm the Manager of State Government Affairs at the National Community Pharmacists Association, NCPA. I want to also recognize Delegate Cullison for her efforts, recognizing the value of community pharmacists and forging ahead to utilize their expertise and skills towards optimal health for all Marylanders. So NCPA represents independent community pharmacies across the United States, including about 395 pharmacies in Maryland. These Maryland pharmacies filled about over 22 million prescriptions last year and employed about over 4,000 employees. So we impact the lives of thousands of patients in the state, and our members are small business owners who are among America's most accessible healthcare providers. Now, according to CDC, their social vulnerability index, 56.8% of independent pharmacies that immunize serve communities that rank high or very high. In addition to that, about 90% of Americans reside within 5 miles of a community pharmacy. So this means that pharmacies are located in areas where it is critical for individuals to get access to various services, not just limited to testing. So linking patients to care, and optimizing prevention measures remains mostly an access challenge. So because pharmacists are easily accessible, many patients do engage with their pharmacist frequently on a monthly basis at a minimum. Furthermore, like other medical professionals or professions, might I say, the pharmacy profession has evolved from a dispensing and product reimbursement based industry to a profession with training and patient relationships to provide outcomes-based services and participate in care coordination efforts. So this invaluable combination of clinical ability and accessibility accessibility is prime for engaging prevention measures, as seen with the COVID-19 pandemic that we're in, as seen with, COVID-19 testing and also administering COVID-19 vaccines. So I just want to stress and emphasize it is important to leverage pharmacists' knowledge, accessibility, and relationship with patients and providers to expand access to care and improve population health. House Bill 810 does just this by allowing pharmacists to order and administer health screening tests, which are then analyzed in a high complexity clinical lab, as previously mentioned. So this has real life implication and value to Maryland's healthcare system, and that's what this is all about. In closing, on behalf of NCPA and independent pharmacies in Maryland, I'm requesting a favorable committee report on House Bill 810 and welcome any questions you may have. Thank you for your time and consideration.
Thank you. Ms. Aaliyah Horton.
Hi, good afternoon. Aaliyah Horton. I'm the Executive Director of the Maryland Pharmacists Association. And as you can imagine, we are always supportive of legislation that seeks to support pharmacists practicing at the height of their education and licensure. COVID-19 has really illuminated gaps, not only in our healthcare system, but also in our legislation and regulatory areas and language that need some fixing. And pharmacists and pharmacies are available to help fill those gaps. And I believe this legislation will really be supportive in moving forward with providing those prescriptive screenings for our patient community. And one area that, as I was looking at this legislation, I have not had a chance to talk to the delegate yet, so I would like to have an opportunity to follow up in some other areas. But just looking at pharmacists are able to order some tests under the lab regulations, but this currently not under their scope of practice. So I think this bill is important to add it to the scope of practice, the Practice Act, just for liability purposes, in that pharmacists carry their own professional liability coverage as well as their practice sites. And it's pretty clear cut when they have coverage if it's included in their scope of practice. So I think this is from a professional society, this is very important to have it in statute and have it in practice in the Practice Act. So I'll leave it at that, and I would like to provide some follow-up documentation to the committee moving forward. So thank you, and I urge a favorable report.
Thank you, Ms. Horton. Rob Garagiola.
Thank you, and thank you, Delegate Cullison, for introducing House Bill H10. Rob Garagiola with Compass Government Relations, representing 2020 Gene Systems. A lot of great comments already made, so I'll try not to be repetitive. As everyone knows, pharmacists are, especially with this pandemic, are on the front lines. They're on the front lines providing testing. They're on the front lines with vaccination now. And we're seeing the role that they're playing in communities all across the state, critical role that they're playing. As was mentioned, pharmacists already can perform a number of screenings. And what this bill does with the amendments that Delegate Cullison highlighted earlier is open that door a little bit more for additional screenings. And when you're considering legislation, the question is always why? Why do we need a bill? And what I would say is if you Google right now, decline in cancer screenings, you will see pages of whether it's the National Institute of Health, the National Cancer Institute, American Cancer Society, daily almost. Cancer screenings and other important screenings are down because of the pandemic. And many are saying there's going to be a huge post-pandemic aftershock with other diseases and mortality that we could avoid if we put additional screenings on the front lines with pharmacists. So what this bill does with the amendments is very narrowly opens the door to certain types of health awareness screenings. It limits it to a pilot of 3 years and then provides for evaluation. So the notion here is we're seeing, because of the pandemic, the success in having the pharmacists be on the front lines with COVID testing and COVID vaccination. And what we're saying is that this bill can be a vehicle to keep them on the front lines today, particularly with the number of screenings not occurring that should be occurring, to avoid that post-pandemic aftershock with other types of diseases and mortality. So with that, would urge a favorable committee report for House Bill 810 with the amendments. Thank you.
Thank you. Are there questions for this panel, this favorable panel? Delegate Saab.
Thank you, Madam Chairman. My question is, can you give me an example? You said it's general screening, and just if you can give me an example, how would that work? The patient will just go to the pharmacy and say, I'd like to have a screening for certain symptoms that I'm feeling, or is it preventative maintenance, preventative, what exactly, how would it work? Because usually if you don't feel good, if you want to, have your physical every couple of years, you go to the doctor. In this particular case, how does it work?
Mr. Ari, do you want to take that?
Sure, and also if Aaliyah would like to add to whatever I have to say. Thank you for your question. And so typically the way it works, you would, a patient at different ages, there are different measures that should be checked at certain times. There are guidelines and protocols that would be followed. And so, for example, if you went to your pharmacist for your yearly flu shot, you're due for your flu shot, right? Your pharmacist they have the information they see, and they can inform you and ask you certain questions to screen you to see if you're eligible for that, and go ahead and fulfill that for you. So it's not it's a very structured process. And again, the Board of Pharmacy also is in position to put in a protocol as the language reads for pharmacists to go ahead and follow. And so I hope that answers your question, and maybe Aaliyah can expand more on that.
Actually, it didn't answer the question, but our rules are one person has to answer. So I'm gonna.
Yeah.
So I still want to get a little bit more specific, because I want to make sure we're not, circumventing the system where actually you don't have to go to a provider and you have people going to the pharmacist asking for certain screening. So what are the guidelines for those screenings? And
Ms. Horton, do you want to swing at it since, and this is your last question, Delegate Saab, for this
What's
panel.
a follow-up?
Right. Aaliyah, do you want to?
I was going to refer to, where is he?
Jonathan?
Yes.
Sure.
Okay, Mr.
Thank you.
Cohen.
Thank you very much. So thank you for the question. So I believe the current language is specific in the bill that these are for basically health and wellness tests. This is not for sick people, people that have symptoms. So examples could include maybe a lipid profile, a cardiovascular, a PSA test for men would be a good example. Many of these tests, and our company has been very active in transferring what is normally a venipuncture test. In other words, a full tube of blood taken by a phlebotomist from the vein to a finger stick test. It's actually not a drop, it's about 10 drops. So there's a lot of, and we're not alone in that regard, there's a lot of tests that can be done at a pharmacy, and compliance with PSA, which is life-saving, is quite low. So the goal is, as Rob said, and particularly during the pandemic, screenings are way down across disease areas, that the convenience of having it at your local pharmacy, having these tests at the pharmacy, will increase compliance and will result in more diseases detected early when they can be effectively treated.
Okay.
Thank
you. Seeing no other, Dr. Hill. I do see a question. Dr. Hill.
Sure.
Delegate Hill. Delegate Hill.
Yes.
Sorry, Delegate.
No. And I think I probably will need to carry this question offline. It's really hard to figure out how to get this down to one. So let me ask, I think it's Jonathan. I'm trying to think of your last name, but I don't see on the screen right now. So you're talking about screenings being down, but physicians don't have to see patients to order screening tests. The labs are open. They can still get them done. I know because I just ordered a whole battery of tests on a patient this week. So I'm not seeing that connection. And so what I'd like you to explain to me is why I'm wrong in seeing this as a cash grab. The tests that you're listing, DNA tests, RNA tests, the proteins and antibodies tend to be some of the more expensive lab tests. As you noted, patients can now order their own tests. They can be marketed to order tests they think are necessary. The pharmacists, they are generally not well trained in differential diagnoses, interpretation, and all that. And you set the cells with the test come back showing abnormalities, they then have to refer them out. So I'm not clear that this is not just sort of almost another direct marketing to patients with an intermediary to convince them to have tests that they may not otherwise need. And for the rest of us, when that's ordered, if the insurance company doesn't agree that there was appropriate reason for it, there's no payment. So the patient may well have to pay out of pocket for the test to the lab at full rate because the insurance is not cutting a discount. So the lab would get way more from a patient having to pay for a test than if the insurance covered it. So tell me why I'm wrong that this is not a money grab.
Well, there are, as I said, there's about 100,000 lab developed tests out there, and many of them are esoteric. We have many of them. Many of them are innovative and are self-pay. And people do pay, are willing to pay very often up to about $100 for tests, so that they really can't get from LabCorp or Quest or some of the standard labs. So this gives individual Marylanders the option, should they choose, and many do, of paying for tests that maybe they don't normally get from their doctor, in part, or in the case of the tests I mentioned earlier, the convenience of getting it at their local supermarket or pharmacy. I have to tell you, even though I'm in the lab business, I'm terrible about going to LabCorp every year to get my lipid profile. I'm just really bad at it. So a lot of people just don't do it. Compliance. So this provides people another option. And again, it's certainly not, nobody has to do, consumers can choose not to purchase these tests. But we believe if you look at the explosion of genomic and genetic tests like 23andMe, there is an ample market and a trend toward consumers opting to self-pay for a variety of tests.
Madam Chair, may I ask my follow-up?
If it's quick, Delegate
Yes,
Hill.
so the question is, what is the pharmacist doing in the middle of it? If it's just a matter of the patient ordering a test, they can do that. The nurse practitioner at the Ready Minute Clinic can. I'm not understanding why the pharmacist is being inserted in the middle of this without the expertise to do.
Well, I mean, Minute Clinic is in some ways a pharmacy-based clinic, but again, these are different options. Some people want to do a test at home and confer with a provider through telemedicine. That's fine. We think this is better because you have a trusted pharmacist who may know the individual, their family. It provides another venue for people that may not want to do it at home. Some of these fingerstick capillary blood draws take more than a drop, and you could use some coaching from a technician. So for a variety of reasons, we think this will be popular. Now, having said that, the bill has a 3-year sunset. So we can try it for a few years. And the idea is the Maryland Board of Pharmacy would then issue a report as to whether this should be extended, terminated, or modified. So we would respectfully urge the committee to basically give this a chance, to give this model a chance. We think it will prove to be very popular.
Okay, thank you. Delegate Riley.
Thank you, Madam Chair. Yeah, I believe this is kind of like a follow-up to Delegate Hill's questions to Mr. Cohen. I can understand if you went to a physician and you have a particular diagnosis that was diagnosed by a physician, and then later on, if you know that you have that certain test that is due or you want to get it because you're feeling bad, you can go to the pharmacist. I get that. But what about the average person? What I think this bill is doing. So I'm an average person. I'm feeling ill. I have no idea
when I'm ill over, but yet I'm just going to go to a pharmacist and ask, how would I know what test to ask for? I mean, that just seems kind of strange to me. So is that what this bill does? I could, as feeling poorly, I can go to the pharmacist and say, hey, pharmacist, you know, I feel this way, blah, blah, blah. And he's going to recommend a certain test.
Yeah.
No.
I'm going to go to Aaliyah for that.
Okay. Thank you.
Yeah, so this also gives me an opportunity to clarify a statement that I made in my testimony, and that it's not a prescriptive screening, it's a preventative screening. So just want to make that clear. And I was just thinking about how recently, over the last couple of months, I don't know if you watched the Today Show, I do, and with Al Roker. And he talked about his prostate cancer diagnosis, and he delayed his follow-up tests because of COVID and not wanting to go into the lab and just lots of different reasons. And I just think of him as an opportunity. If he could have gone around the corner to his Dwayne Reed and gotten the test, he would have gotten his results back sooner. He ended up having to have prostate removal surgery. But just thinking about folks in that sense, for those regular preventative screening tests that you know you need to take, that you may have an interest in taking. And, you know, sometimes I'll be frank, the insurance agencies, yeah, they may not want to cover a test, but sometimes I want to know. And if they're not going to cover it, then I still want to get the test taken, and just from a patient perspective. So that's what I would say. It's not for prescriptive. And another follow-up, if you think about when you do go to LabCorp, with my current provider, if I get tests, it's all on a database. I go in, I see all the tests, they're within a range, and I get a reference of whether I need to do something or not. That information then goes to the prescriber, to the physician. It's not for the pharmacist to make a diagnosis from there. It's to refer.
Okay. Thank you.
Seeing no other questions, we will move to a panel of unfavorables. And we'll start with Elaine Crane. Elaine?
Okay, unmuting. Good afternoon. My name is Elaine Crane. I am a nurse practitioner in primary care representing the Maryland Nurses Association. And I'm glad to go first. I actually just have real world examples in not much. Have the first. Going to the PSA example that was brought up, an elevated level may indicate prostate cancer, but PSA levels can also be affected by other things, such as an enlarged prostate, a urinary tract infection, and not just cancer. So further examination and a history are needed to appropriately care for a patient. Another test that produces results without diagnosis, which is the language in the bill, could be a finger stick for glucose or blood sugar. A high or low reading is not a diagnosis, but either reading can have a myriad of meanings and not just diabetes. Much depends on a complete medical examination, a dietary history from the patient, and a knowledge of their family's medical history. High sugars can also mean that a patient low can be a measure of alcohol take or occur with medications in combination with others. I respect the knowledge base and access to care my pharmacist colleagues can bring to our healthcare system. However, practitioners, not pharmacists, have all the necessary information about their patient's medical history, family history, medications, and are trained to interpret tests results in order to treat their problems. The buzzword here to remember is buzzwords are fragmented care, or perhaps too many cooks spoil the broth. I am asking for a non-favorable report on HB 810. Thank you.
Thank you, Ms. Crane. We'll move to Matthew Celentano.
Good afternoon, Madam Chair and members of the HGO Committee. My name is Matt Celentano. I'm here today on behalf of the League of Life and Health Insurers, which is comprised of health companies Aetna, CareFirst, Cigna, Kaiser, and United. respectfully opposed to House Bill 810. First, our concern relies with the definition of health awareness. It's concerning. It really could mean anything. And there is, if there's a particular issue that proponents want to address, we would ask them to really focus the language. It might be the intention of the proponents, but the bill is not limited to private pay patients as written. Since the bill falls into the pharmacist's scope of practice under HB 810, insurers would have to pay because carriers pay for lab test administration by other healthcare providers. As well, our contractor providers know how to send lab specimens to labs that we contract with in-network labs. We don't know how the pharmacists under this bill would have any idea about those contracted relationships. And without that knowledge, it could lead to tremendous consumer cost exposure. Lastly, what would happen with the lab results when they go back to the pharmacists? How would they be qualified to discuss results or next steps with the patient? If it's the primary care physician, why didn't they order the appropriate tests after consultation with the patient in the first place? Who consults after? In the case of an uninsured patient, how would a referral to a practitioner be adequate? Who decides where that referral should go and what's the most appropriate course of action? And lastly, who's liable for the patient? Is it the pharmacist now? We think that this bill, although the intentions might be clear and admirable, there's far too many questions we don't have the answer to, and we urge an unfavorable report. Thank you very much.
Thank you. And Steve Wise.
Thank you, Chairman Cullison and members of the committee. Steve Wise on behalf of MedChi, several provider specialties and community health centers. You have a written statement from us. The points that I would make that haven't already been made is, first, I'm listening to the testimony, and it's not often, as this committee can appreciate, that the nurse practitioners, the physicians, and the insurance companies are all testifying on the same side of a bill. So please take note. But with regard to the increased access argument, I think you also have to weigh the other side of that, which is you want the access that people have and the healthcare they get to also be efficient use of the healthcare system and quality use of the healthcare system. And that's why testing and so forth by primary care provider is a precedent to ordering lab tests. I would note to you that physicians, for one, are subject to discipline for overutilizing healthcare and lab tests. In other words, they've got to be able to justify why they ordered the test. And if they don't, they're subject to discipline for that. They've not met the standard of care. And the final thing I would note is that several references were made to this being convenient during COVID. Maybe it would have helped things along during COVID, but I think we're all hopeful that COVID is about to go away. And you shouldn't make long-term policy decisions based on what we all hope is an event that we never see again. So thank you very much.
Thank you. Questions from the committee? I see Delegate Kelly.
Thank you, Madam Chairman. And my question is for Ms. Crane. I know your audio was going on in and out a little bit during your testimony, but I think what your point was that I'm not sure if she can hear me that I'm asking the question. Okay, good. That a patient might go there for a PSA test or a glucose level test to a pharmacist, and that when the results came back at the time that the pharmacist might be referring them to a PCP for interpretation, for example, that period would be potentially detrimental for a patient. I'm thinking of, I like to be a Google doctor, but I'm not a doctor and I'm not a nurse practitioner. But often, in my chart, if I get my test results back, I think they mean one thing and they terrify me. And then my provider will be like, no, in your situation, ignore Dr. Google. Is that your concern?
Yes, basically. And that happens all the time with my patients who get testing that is not done through someone who can immediately interpret it. Also, too, part of the bill does state that the pharmacist will refer to primary care, but there is a shortage of primary care in Maryland, so that's going to be very difficult for them to do. And I'm afraid exactly that patients will panic or perhaps seek incorrect care for
Thank you very much.
Thank you. Are there any other questions from the committee? Seeing none, that completes the hearing on HB 10. Thank you all for coming to testify today. And we will move to HB 811, also sponsored by Delegate Cullison. And again, I am going to just introduce the bill and then turn it over to turn my 5 minutes over to my panel. There comes a time in all of our lives when we have to update our statutes, and for the Board of Licensed Social Workers, it is now, and that's what this bill does. It updates the statute to reflect current practices, best practices, and it makes the standard much more current. I need to say thank you very much to the executive director and the president of the board for working with the Association of Social Workers to make sure that the language in the statute was agreeable and worked for both, for everyone. And the product that we have here today is one that they all share in. So with that, I am going to turn it over to Stanley Weinstein, who I am very grateful to for bringing me this bill. And Stanley, you're going to tell us about what the bill does. Mr. Weinstein?
He should be in the room.
Yeah.
Can you hear me?
Now we can.
Okay, thank you.
There we go.
I'll get used to this technology soon. Madam Chair, Delegate Cullison, and committee members. I'm Dr. Stanley Weinstein, Executive Director of the Board of Social Work Examiners. House Bill 811 incorporates changes to our statute following a complete review of our statute and regulations. Some of the changes include: it removes dates no longer relevant, it removes obsolete language, and adds some language to enhance mobility and make our statutory language more consistent with neighboring states. It discontinues the licensed certified social worker license in 2023. It has been replaced by the licensed master social worker independent license. Currently, there are only 350 of these, what we call LCSW licenses active out of over 16,000 social workers in the state of Maryland. This bill eliminates also the language of licensed graduate social worker, which was replaced by licensed master social worker. Another change is, as you may know, federal government employees are exempt from our licensure. However, this bill states that if you have a Maryland license, even though you are a federal employee, you must comply with Maryland law, pardon me. The bill significantly reduces the hours of clinical supervision from 144 hours to 100 hours. This will make us consistent with our neighbors in Virginia, DC, New York, and Delaware. We are focusing more on the quality of the supervision rather than the hours. We're adding discipline history to our electronic records so that an employer or client were to go to our verification page to learn about a social worker, this information would be available. The bill also replaces the Rehabilitation Committee, which has never existed, to a rehabilitation process where we can evaluate behavioral health problems, physical health problems, and recommend treatments. HB 811 also updates the maximum fine that other state laws have previously increased from $5,000 to $10,000. Lastly, the bill changes the name of the statute from the Social Work Act to the Social Work Practice Act. There was an amendment that changed the date we begin to require all social workers who haven't had a criminal background check to get one. It was scheduled for 2021, but the board felt that during this pandemic, we did not feel this was the right time to require this. In addition, the FBI runs a program called RAP Back, which notifies the board in the event a social worker has been found guilty of criminal activity anywhere in the country. It's not fully operational at this time, and we anticipate that by 2023, it would be. So in conclusion, the Maryland Board of Social Work Examiners supports HB 811 as amended and requests a favorable report.
Sorry. Thank you, Mr. Weinstein. I'd like to call on Mr. Gerard Farrell.
Thank you, Madam Chair. Good afternoon, members of the committee. Thank you for the opportunity to appear before you today on the matter of House Bill 811. I am Jerry Farrell, Chair of the Maryland Board of Social Work Examiners, and I speak today on behalf of the full board, and I'm afraid I'm going to be a little bit repetitive of our Executive Director, Dr. Weinstein. I should also note that I am not a social worker. Rather, I am one of two consumer members on the board. I am a retired Navy captain and a retired nonprofit executive, and I've been a member of the Board of Social Work Examiners for more than 4 years now. Our board unanimously supports the bill, which is essentially designed to clean up the Social Work Practice Act, make the language in the statute consistent, and update the board's procedures. These revisions come after a long and assiduous review of the statute by our Statute and Regulations Committee and ultimately the full board itself. As Dr. Weinstein has already outlined, the most significant changes proposed are to reduce the number of clinical supervision hours required to obtain a clinical license from 144 to 100. This is a considered effort by the board to support the national movement to license mobility and aligns us more closely with the licensing requirements of our neighboring states. It also replaces the Social Work Rehabilitation Committee, a committee never operationalized by the board, with a social work rehabilitation process that more closely aligns with the actual practice of the board over the past several years. And finally, it delays the requirements for criminal background checks from 2021 to 2023, a necessary change given the delays in obtaining such checks caused by the ongoing pandemic. Our board has worked closely and collegially with several other interested parties on these changes, and we believe that we have a bill that is straightforward and uncontroversial. I'd like to thank Delegate Cullison for her leadership in pulling this all together, and we urge a favorable report by the committee. Thank you.
Thank you, Mr. Farrell. I'd like to call on Daphne McClellan, please.
Good afternoon, Madam Chairperson and members of the committee. I'm Dr. Daphne McClellan, Executive Director of the Maryland Chapter of the National Association of Social Workers. And I'm here to urge you to support House Bill 811. It's been a pleasure to work with you, Delegate Cullison, in making sure that everything was acceptable to both parties. And we really appreciate you inviting us to meet with the Board of Social Work Examiners. There was initially an issue in the draft that we were concerned about, and that was all ironed out. And so we are really pleased to support this bill in its entirety. We believe that the amendment also to change the criminal background check for 2 years is very helpful during this pandemic. So we think that's a good amendment to have as well. So we believe that this is a cleanup bill clarifying many aspects of our current legislation, and that it's very helpful. Thank you, and we urge your support.
Thank you very much. And again, I want to say thank you to all of you for working together to a really good product that will take us into the next round of review of the statute. So thank you. Are there questions from the committee? Okay, seeing none, that concludes the hearing for HB 811. Thank you all for coming and testifying today. And we will move to HB 780, Delegate Kerr. That's Maryland Health Benefit Exchange, State-Based Young Adult Health Insurance Subsidies Pilot Program. Delegate Kerr. You're on mute.
Okay. Thank you, Madam Chair, and good afternoon.
members of Health and Government Operations. House Bill 870, the Maryland Health Benefit Exchange Young Adult Health Insurance Subsidies Program. UB Blake was born in Baltimore in 1887, and he lived to be age 96. He was one of the most important figures in early 20th century African-American music, and someone whose longevity made him a storehouse of the history of ragtime and early jazz music and culture. He is reported to have said on his 92nd birthday, "If I'd have known I was going to live this long, I'd have taken better care of myself." Maryland's reinsurance program and health benefit exchanges have made healthcare affordable for the vast majority of Marylanders. Still, however, 6% of our families, friends, and neighbors remain uninsured. And the vast majority of those are young Marylanders between the ages of 19 and 34 who earn too much money to qualify for federal subsidies. House Bill 780 provides a means for young adults to reduce the amount they pay for health insurance plans in the individual health insurance market, requiring the exchange and consultation with the Maryland Insurance Commissioner to establish subsidy eligibility and payment parameters for calendar years 2022 and 2023. The intent of this bill is to get health insurance for more Marylanders, improve the risk pool by enrolling young, healthy people, and providing long-term stability to the healthcare market in our state. So let's heed UB Blake's advice and help young Marylanders take better care of themselves so that they too may live to be storehouses of the history of their individual areas of expertise. And I would like to yield the balance of my time to Johanna Fabian Marks from Maryland Health Benefit Exchange, followed by the rest of my panel.
Thank you, Delegate. Joanna?
Thank you, Madam Chair, Vice Chair, and members of the committee for the opportunity to testify in favor of House Bill 780. I'm Johanna Fabian Marks, the Policy Director at the Maryland Health Benefit Exchange. Over the last several years, Maryland has taken significant steps to stabilize the individual market, as Delegate Kerr noted, including implementation of the state reinsurance program, which reduced premiums in the individual market by nearly a third since 2018. These efforts have resulted in the individual market growing by 9% during the most recent open enrollment period, nearly 235,000 individuals. But despite this achievement, about the same number of Marylanders are eligible to enroll in private health insurance, but are still uninsured, with young adults aged 18 to 34 being the largest group of uninsured. In 2019, we surveyed uninsured young adults, and about 70% told us that they would like insurance but find it difficult to afford. Over the last year, the exchange worked with the MIA to commission an actuarial analysis of a state premium subsidy program, convened a stakeholder work group, and submitted a report to the legislature on their findings. The actuarial analysis projected that providing state premium subsidies to young adults would increase young adult enrollment, further stabilize the individual market, and benefit everyone by bringing down premiums for all enrollees. While projections were based on a program at a $30 to $60 million per year scale, and the stakeholder work group recommended a program near the top of that range for maximum impact, we anticipate that the proposed pilot program will demonstrate positive effects and provide valuable data. Our stakeholder work group reviewed the actuarial modeling and considered inequities in the current individual market, including data showing that Black and Hispanic young adults are 2 to 3 times more likely to be uninsured than white young adults in Maryland, and the state reinsurance program, which has done such a remarkable job reducing premiums, primarily benefits those with higher incomes, not our young adult target population. The work group concluded that a young adult subsidy would both strengthen the market and mitigate these inequities, and unanimously recommended that the exchange target a state subsidy at young adults. House Bill 780 acts on these recommendations by authoring the exchange to implement a young adult subsidy pilot program in 2022 and 23 and funds the program at $10 million per year. The pilot would allow us to gather data on the impact of the program to inform a decision on whether to continue or expand it past 2023. Before I conclude, I want to briefly address 3 issues related to implementation. First, funding. Funding for the pilot would come from state funds currently dedicated to reinsurance, so no new revenue is required. The reinsurance program has received more federal funding than initially anticipated, so we have unspent state funds that can be used. Second, you may have heard that Congress is proposing to expand federal subsidies for 2021 and 22. The proposal would improve affordability, but would still favor older adults. As a result, a young adult state subsidy would still be beneficial and to work in concert with any federal changes. And lastly, implementation timeline. The bill proposes implementing starting in January 2022, and we are prepared to meet that timeline. We welcome the chance to get assistance to young adults out the door, and the proposed timeline also aligns with our reinsurance waiver, which has benefits I'd be happy to elaborate on. So in conclusion, the pilot would target our largest group of uninsured, address inequities, and provide timely data to inform a decision about whether it makes sense to continue or expand the program. Thank you again to Delegate Kerr for introducing the bill, and to the committee. I encourage a favorable report.
Thank you. We're going to go to Allison Taylor.
Hi, good afternoon, Madam Chair and members of the committee. My name is Allison Taylor, and I'm here today on behalf of Kaiser Permanente. Kaiser Permanente is one of the carriers that provides insurance through the individual market, and we've had the great honor of participating on the stakeholder work group over the interim and having a voice on with the committee's work on a number of market reforms, including reinsurance over the past several years. We're in strong support of this legislation for the reasons Ms. Fabian Marks has outlined, and we agree with the actuarial analysis that they commissioned that projects that this would have significant, it would increase enrollment and coverage in the individual market. As Ms. Fabian Marks noted, there is going to be some congressional action sometime soon addressing, potentially adding some premium enhancements federally. So of course, we think that should be part of the discussion here in terms of making sure that whatever the committee decides to move forward with is the best for all Marylanders. So thanks for the opportunity to testify, and we urge a favorable report.
Thank you. Lee Hudson. Lee Hudson, are you there?
There we go. It was not letting me.
There he is.
Yeah, it was not letting me unmute. Thank you. I appreciate your indulgence. Madam Chair, members of the committee, I thank you for the opportunity to testify. My name is Lee Hudson. I am assistant to the Bishop of the Delaware Maryland Synod, Evangelical Lutheran Church in America. We are a faith community with congregations in 3 different synods in the state of Maryland, from Ocean City to Red House, Maryland. And Delegate Kerr has wonderfully stated our position. We are here because we committed ourselves in 2003 to advocate for healthcare, access to healthcare for all people in the United States and its territories. Our understanding is this bill will expand coverage in the state of Maryland. And I want to say we're particularly happy that this will get at one of the health care inequities that sort of persists in these markets. With that, I am here simply to say we support this bill and urge your favorable report.
Thank you. Muta Bain.
Hello, my name is Mukta Bain. Thank you so much for giving me this opportunity. And I strongly do support House Bill 780. This will help me, someone like me, and also other people with similar situation in Maryland. Back in August 2020, I was hired as a contact tracer for Baltimore County Department of Health. They did not provide me with any insurance or other people because we were hired as a contractor. Because of that, and because I made a little bit more money, I was not qualified, still not qualified for Medicaid for this year. So I went to Maryland Health Connection to see my options. The subsidies that are available over there, either the premium or the deductible are too high for me to pay every single month. So I was worried because I do have medication which I need to take every day, and I do have a therapy session which I do every 2 weeks. So I was really scared, still are scared, and I felt scared and anxious, and I don't think any of you guys want to feel not having healthcare. So because of COVID-19 pandemic, thankfully, Medicaid was extended for me for 2021, but I'm not sure for how long. So I know I'll be in a situation soon to decide, should I pay for my rent or for my health coverage? So I think, well, I believe from this bill, there are going to be very positive outcomes. And please think about us and our health, and please pass the bill. Thank you.
Thank you, Ms. Bain, and thank you for coming and speaking to us about your personal story. We appreciate that. Stephanie Klepper.
Hi, thank you. Chairman Pendergrass and members of the committee, thank you for this opportunity to testify in support of House Bill 780 on behalf of Maryland Citizens Health Initiative. And thank you especially to Delegate Kerr for sponsoring this very important legislation. Thanks to your committee's leadership, Maryland truly is a leader in the nation in connecting residents with quality, affordable health coverage through innovative programs you've passed out of here, like the Easy Enrollment Program. However, hundreds of thousands of Marylanders remain uninsured, with young adults making up the age group most likely to be uninsured. Within this age group, there are large racial and ethnic disparities in coverage, making this a health equity issue. The COVID-19 pandemic is ravaging the health and economic well-being of Black and Brown communities, which adds to the urgency of resolving these inequities. Help can't come soon enough, and state-based subsidies will help young adults like Ms. Bain access much-needed health coverage while stretching Maryland's dollars to help the highest number of Marylanders possible, as well as stabilizing the individual market by bringing in more young, healthy people. The pilot that would be created by this legislation is the result of years of thoughtful analysis and discussion by stakeholders on how to make coverage more affordable for Marylanders. The need is great, and I advocate for as quick an implementation as feasible, both so that young adults who would benefit from this pilot can start getting the coverage that they urgently need, and so that we can collect useful data to help guide Maryland in addressing affordability on a larger scale. 5 other states have already created or passed legislation to create their own state subsidies programs, and I hope that Maryland will be next with the passage of this bill. So thank you for this your consideration, and I urge a favorable report on House Bill 780.
Thank you. Thank you all for coming to testify. Thank you, Delegate Kerr, for bringing us this bill. Are there questions from the committee? Delegate Lewis.
Thank you, Madam Chair. Thank you to the bill sponsor. I think it's a great idea to make it easier for young people to pay for health care. The representative from MHBE mentioned that, referred to the benefit options that would be available under the pilot. And I don't know where the MHBE person is on the screen. Oh, there you are. Hi, Johanna, there you are.
Right.
Madam Chair, if it's all right, could you tell us more follow-up on that benefits issue?
Sure. So the bill would allow MHB to create a supplemental state subsidy that would further reduce premiums for young adults. So this would help to make their premiums more affordable. It wouldn't necessarily address co-pays or things of that nature, but it would make premiums more affordable, which is our kind of first goal to help. uninsured rate.
Is it income based or age based? How does okay?
Sure.
So,
yes, the bill is sets up eligibility parameters to be up to 400% of the federal poverty level and up to age 40. But due to the pilot nature, we might, and the funding available, we might further narrow those parameters based on the decision of the MHBE board in conjunction with the MIA.
and just so everyone understands what 400% FPL is, could you give us the dollar range of that for a single person?
Yeah,
I know you know it by heart.
That's up to roughly $50,000 for an individual.
And I'm assuming that would be helpful. Yeah, okay, thank you so much. And thank you also, Ms. Bain. Great testimony.
Yeah. Are there any other questions from the committee? Okay. Seeing none, looks like we are embarking on considering some brand new territory in healthcare, in which I really appreciate the work of the commission to protect our Maryland's healthcare and the work group that worked on this. So we look forward to further work on it. And that concludes the hearing on House Bill 780. And we will go to the last bill of the day, which is House Bill 903. This is Delegate Bridges, and this is a task force to study the Maryland Public Guardianship Program. So Delegate Bridges.
Yes, thank you.
There he is.
I'm here. Actually, this is my first time being in front of this committee, so I hope you all go easy on me.
Welcome.
Thank you. Chair, Vice Chair, members of the committee, thank you again for the opportunity to present this bill. Again, I'm Delegate Tony Bridges. This bill does focus on the Maryland Guardianship Program. As you know, the Guardianship Program is there to serve our most vulnerable adults in our communities. But the purpose of this bill is really to establish a task force that looks at the program, to assess the program, compare practices of other local area agencies, analyze those practices and practices of other states, examine research and guidance related to best practices, and really make those recommendations available to the governor and the General Assembly. So as you know, the Maryland Guardianship Program serves individuals 65 years of age or older who have been deemed by a court to lack the capacity to make or communicate responsible decisions concerning their health and daily living needs. They definitely have some complex and often multiple stakeholders who help them with these decisions. As a last resort, the law as it is currently authorizes the Secretary of the State Department of Aging or the director of a local area agency on aging to be appointed as a guardian when there's no other option for guardianship. Those agencies work with a host of organizations to ensure the well-being of individuals in need. With many local entities with these responsibilities, they're often under-resourced. The number of older adults with cognitive impairments is supposed to increase as the older adult population grows. And so there's a long-term structural problem that has important fiscal implications as well. There are limited dollars, as you know, for programs like this, despite the increasing caseloads that these programs have. The courts appoint the guardians, but the funding isn't based on the appointments of those courts. The funding is really appropriated separately from the judicial process, so the funding is really not aligned. And some jurisdictions have a higher number of guardianships without sufficient funding. We've even seen that with the pandemic, we're having an effect on this process. So as the courts have transitioned to virtual hearings, some patients are left in hospitals with waiting for care from guardianship determinations. And so there's an impact on the patient as well as the hospital. And so this is a partnership. There are many stakeholders in this partnership. And so we want to determine the best care for our vulnerable adults. And that's why we need to take a fresh look at the process and ensure that we're working with all the parties to get the best end results for our vulnerable adults. Now, I noticed that I know that there are a number of amendments that have been requested to consider, and I really do consider them to be friendly amendments for this bill. One of the biggest glaring amendments that was left out of this bill is to have a representative from the Department of Human Services who really runs the gamut of this program. And so It's really good to have someone from the Department of Human Services as a representative, as well as a hospital representative, a disability advocate, and then there were a couple of organizations that specifically wanted to be called out as a part of this task force, which I think just shows the need to have a task force to look at this in a holistic manner. And so for those reasons, I asked that the committee give us a favorable report so that we can start the task force. And I do have a panel who's here that can give sort of the technical expertise and background as to why this task force is so desperately needed. And so with that, Madam Chair, I'll turn it back over to you or to the members of my panel.
Delegate Bridges, is there someone you would like to follow you and have the rest of your time?
Sure, if Susan Francis.
Okay, Susan Francis.
Hello, my name is Susan Francis. I am the Executive Director of the Maryland Volunteer Lawyers Service. Thank you, Chair Pendergrass, Delegate Cullison, and members of the committee for hanging in there and getting the last round of testimony today. I'm here to recommend a favorable report for House Bill 903, establishing a task force for Maryland public guardianship. My program, the Maryland Volunteer Lawyer Service, is the oldest and the largest pro bono program in Maryland, where we provide free civil legal services on a variety of really important legal matters, and one of them is guardianship. And in guardianship, we actually have two programs. We have one program that is our private guardianship, and that's for individuals, those loved ones when they're older adult or someone else in their life has lost their legal capacity and they're seeking guardianship over them. And that program is statewide. And then we have a second program, which is one that I'm here to talk about today, in the public guardianship realm. We represent 450 alleged disabled individuals in Baltimore City and in Baltimore County every year, both in initial guardianship hearings as well as twice a year review board hearings. When we are first court appointed for those individuals, one of the first things that we do is try to find a family member, a friend, a trusted other that can step in and serve as that decision maker in that capacity. And you know, when we can't, that's when we have to start looking at public guardianship. And I just want to reemphasize what Delegate Bridges said, which is that public guardianship is actually the last resort for these individuals where we've not been able to identify someone in their lives that really can step and serve in that capacity. One of the challenges around that is when you don't have those sorts of assistance, is that person becomes potentially very vulnerable towards exploitation. You've heard, you know, some very tragic testimony today from individuals when they had loved ones trying to take care of those individuals. For individuals that are in public guardianship, they don't have those individuals that can step in. And so making sure that those individuals are taken care of is critically important. Additionally, these individuals often have complex needs, as Delegate Bridges has also identified. Most of them have very serious medical needs, mental health barriers, and often can't advocate for themselves. And we know that individuals that are socially isolated often are potentially at risk of exploitation. The private guardianship went through a review a couple years ago where they looked at the rules and they looked at the practices and they improved the system. And that hasn't happened in the public guardianship realm for a very long time. And so we believe that everyone benefits: the adults, the attorneys, the case managers, the healthcare providers, the residential programs. They all benefit when we work together and have a comprehensive and coordinated effort that really implements best practices. Thank you for your time. That's why I encourage a favorable report.
Thank you. Asia Williams?
Asia won't be with us today.
Okay, thank you. Juan Tang?
Hi, good evening. Thank you, Madam Chair and members of the Health and Government Operations Committee, Thank you to Delegate Bridges for sponsoring this bill. On behalf of Baltimore City Administration, my name is Hyung Tan. I'm the Deputy Commissioner of Aging at the Baltimore City Health Department. I also serve as the public guardian for persons 65 and over in Baltimore City. We've submitted written testimony on this bill explaining why we need a task force to modernize the state's public guardianship program. I believe that HB 903 will enable the state of Maryland to not only draw upon the knowledge and commitment of those who do this work every day, but also look at best practices and standards that have been developed by national experts. The task force envisioned in this bill will help our state prepare for the growth of the public guardianship caseload as the population of older Marylanders grow. Today, however, I do want to spend my time to talk to you about this bill as it relates to its importance in human terms. One of the things that I have to say is that the most profoundly important duties that I have as an Area Agency on Aging Director is to be the legal guardian for persons 65 and over. And if you contextualize the weight of this responsibility, think of it as being a caregiver to those who can't care for themselves. My colleague has mentioned this, but I'm also the legal guardian of 2 young children and as their mom. And in Baltimore City, as the Area Agency on Aging Director, I'm also the legal guardian of 182 individuals, women and men who are 65 and over, many of them suffering from dementia, some experiencing mental behavioral health problems, and all of them are under our care because they can't care for themselves. Our court only places a person under public guardianship because there's no alternative. And they're much more likely to be victims of abuse and neglect and exploitation in the context. And in the context of this pandemic, they're at the greatest risk of hospitalization and death. Does that mean my time is up?
Yeah, if you could just.
Yes, okay. We owe it to our guardianship client to do the best for them, to ensure that they have the best quality of life, and to be able to meet the standards, we need more support. Therefore, Baltimore City urges a favorable report on House Bill 903.
Thank you. Michelle Douglas.
Good afternoon, Michelle Douglas on behalf of M4A, the Maryland Association of Area Agencies on Aging, which is the 19-member organization made up by each of your local area agencies on aging from all around the state. AAAs represent the front line in Maryland's challenge to meet the complex and varied needs of well over 1 million older adults statewide. M4A supports House Bill 903, which addresses the need to strengthen Maryland's public guardianship program for adults 65 and older. Public guardianship for older adults is a vital service that the AAAs provide for some of the most vulnerable people in our state. In FY 2019, the 19 AAAs assumed guardianship responsibilities for 825 older adults and helped many additional older adults find alternatives to public guardianship. AAAs perform this vital work with minimal funding from the state. In fact, the funding allocation for the public guardianship program has not increased for a number of years, although the caseloads continue to increase. And as the population of older adults around the state continues to grow, the number of people needing guardianship will also increase. As these caseloads increase, AAAs will face a crisis when the resources to support the public guardianship program will not be adequate to meet the need. And I can tell you that many of the AAAs around the state are already stretched way too thin. House Bill 903 is a much needed proactive response to ensure a strong public guardianship program for older adults in the state of Maryland. The time to do this work is now, before there's a crisis. And the task force will draw upon the practical experience of area agency staff who do guardianship case management work every day with dedication and creativity. We urge a favorable report.
Thank you very much. Are there questions for this panel? Delegate Hill.
Thank you, Madam Chairman, and thank you, Delegate Bridges, for this good bill. I don't know who can answer the question, maybe Ms. Douglas or Ms. Francis. So in 2019, elder law section, the estates and trust section, disability section of the bar were supposed to do a summer study on guardianship and all of these issues. They didn't meet until January 2020, and I've heard no report. Now, is this task force piggybacking on what that group was doing? Is this totally separate, or is there any connection at all? Are we being redundant here? Can anyone help me understand what that is?
So I'll take a crack at it. I don't serve on the MSVA estates and disability law section, although I do monitor their emails. I'm not aware of any active action. I think these might complement but not be duplicative. And the reason I say that is, I was thinking about that on the private guardianship side, and when that analysis was done, it was really done based through the court rules and the court practice. And in this context, that's certainly an important piece to it. But as you've heard from these other panelists, because of public guardianship, you have so many additional players. Like the legal piece is a part of it, which is why I'm here, but there's also, the local area of agencies, the residential programs, the hospital, so I don't think that it would be duplicative, and that this task force would actually bring together, as Delegate Bridges had mentioned, kind of that really broader coalition, as opposed to most of that MSBA work really, because that's who they are, right, is really thinking about this from the legal structure side and not the coalition side.
Thank you. I appreciate that.
All right. I believe Kimberly Burton from the Mental Health Association was signed up to speak.
Yes, she is. And since she's favorable with amendment, I was taking her next after the questions. But thank you, Delegate Bridges. Delegate Bagnell.
Thank you, Madam Chair, and thank you to the bill sponsor. This seems like it's very much needed. I was just wondering though, because public guardianship sort of has like the two arms, the 16 to 65, the 65 and above, but it looks like most of the testimony is speaking to that elder population. Is the task force looking to review public guardianship specific to the elder population? Or are you looking for the broader population?
Thank you, Delegate. That was a question that some of the advocates had also brought to my attention. This should focus on the elder population, the 65 and older, not the whole gamut of the 18, to 65. So it's just 65 and older.
Thank you. Thank you, Madam Chair.
Thank you. Any other questions from the committee? Then I'd like us to hear from Kimberly Burton, who's favorable with an amendment.
Thank you very much. And to the question that was just asked, I would like to say that the caseload for older adults seems to be much heavier than it does for the younger adults. And so that's one of the reasons that this needs to happen. Hi, everybody. My name's Kim Burton. I recently left my position as the Director of Older Adult Programs for the Mental Health Association of Maryland, where I served for 20 years. And I've also been the co-chair of the Maryland Senior Citizens Action Network for the past 8 years. But most relevant to today's hearing has been my work as a former appointee to the Baltimore City Public Guardianship Review Board, which is kind of a mouthful to say quickly. I was on that from 2015 to 2018, maybe a little bit longer. And I have really a great appreciation for the opportunity that I have here today to try and influence some positive change that I couldn't possibly make happen on the review board. I don't even have words for the great need for revisions, for new standards, for best practices. It's absolutely critical to establish this task force, and most importantly, to examine the best practices and make recommendations, but also to update some of the things in the statute. I heard Delegate Cullison say earlier, she said, there comes a time when you need to update the statute. And I thought about this in particular because it talks about habitual drunkenness being a reason that people might be in the guardianship program. So that, huge problems that I saw in this program were the number of older adults on psychotropic medications. Sometimes I would count up to 13 psychotropic medications that these folks would be on. The caseloads were completely unmanageable. We have case managers who are so dedicated. And they have to do the work that Delegate Lewis Young was talking about, only they have to do it for upwards of 35 people. So it's not out of neglect or fraud or anything other than improper resourcing and a lack of standards that we are having such problems with the Public Guardianship Review Board. So I strongly urge your favorable report on House Bill 903.
Thank you, Ms. Burton. Are there questions from the committee? Delegate Bagno.
Thank you, Madam Chair, and thank you, Ms. Burton. If you could just help me and perhaps other members of the committee, can you just talk us through what the process of being a public guardian is? Is it a licensure? Is it a combination of different organizations? What does that look like?
I would actually defer to Susan Francis to answer that question.
Not to kick the can, I was actually going to suggest Hyung. He serves as the public guardian for Baltimore City. Like, she might be, I mean, I'm happy to talk about the court process, but I think Hyung might be the best equipped to answer that question.
Let's go to Ms. Tan.
Sure, not a problem. So who serves, as Delegate Bridges had mentioned in his introduction, it's the 17 Area Agency on Aging Directors. Appointed guardianship clients are appointed by the court, the circuit court, and Ms. Francis can talk a little bit about that. But once they are appointed, they are delegated under our care, the Area Agency on Aging Director.
Okay. Delegate Bagno's that.
Thank you.
Ms. Burton, I had a question, I guess, and maybe it's been a long day and I just didn't hear it. The amendment that you're looking for in the legislation, what does it do?
I support the friendly amendment to add somebody from DHS, Department of Human Services, so that we can have some consistency because it is one whole program. And I would also like to support an amendment that I believe was offered by AARP, that a member of the courts be represented on this task force.
Thank you. That's helpful. Delegate Saab, you have a question.
Thank you, Madam Chairman. Delegate, thank you for bringing this important bill. Before you got here a couple years ago, I worked closely on a similar bill which addressed visitation under guardianship, which basically was targeted specifically for people that have been isolated. So this is actually definitely a step in the right direction. The question that I have is, and I may have missed it at the beginning, how long does the task force has to study and then send us back the report, and who does it send it to?
Yeah, thank you for the question, Delegate. The task force, I believe, starts in July. The recommendations are due by January. And I believe it should be due to the governor and the General Assembly. I can make sure that that is the case, though, but I believe that's who it's due to.
It will be due by January of 2022.
Yes.
Okay. Thank you. Thank you, Delegate.
It begins. I'm sorry. It takes effect July of 2021 and remains in effect for one period, end of June 30, 2022. I'm sorry, it is January 1st, 2022. That's when the report is due. My apologies.
So that will give us enough time if there's any bills put in for the following session. So thank you, appreciate it.
Great, thank you. Seeing no further questions, it was nice to have you in the Health and Government Operations Committee, Delegate Saab. That ends the work at the desk today. Thank you all to the committee. Thank you to all who spent their time and gave us their testimony. And we hope that